Good morning. Good morning. I think we'll go ahead and get started. This meeting will now come to order. Please note that this meeting is being recorded, and we will start with a roll call and appreciation for folks being here.
Good morning. Joan Allen.
Present.
Thank you. And please use your mics if you can. You'll just press the button so that the light turns from red to green. Barry Arbuckle.
Present.
Eliza Arjoyan.
Present.
Stephanie Klein. And that's present for the record. Carmen Comsty. Adam Daughtery.
Present.
Parker Duncan Diaz.
Present.
Hector Flores. Sarah Gavin. And that's present for the record. Stacy Frontis.
Present.
David Joyner. Ivana Krasinovich. Tam Ma.
Here, present.
Carolyn Nava.
Good morning. Present.
Mike O'Day.
Good morning.
Janice O'Malley.
Present.
Sumana Reddy.
Present.
Yolanda Richardson.
Present.
Kiran Savage Sangwan. Andrew C.
Present.
Sarah Sorokin.
Present.
Ken Stewart.
Present.
Suzanne Usage.
Present.
Yvonne Wagner.
Here.
Renee Williams.
Present.
Anthony Wright.
Good morning.
Abby Yant.
Present.
Thank you. So with that, we have a record of who is in attendance. And again, want to welcome you and wish you a good morning. I'd like to start by introducing our attending board members. As you know, for every advisory committee meeting, we have at least one board member in attendance. So very pleased that Dr. Sandra Hernandez is here with us in person, and that Rick Cronick is joining us online. Are you with us, Dr. Cronick? Online. We believe so.
Muted. Can you hear me?
Yes, thank you very much for being here.
Good morning. Yeah.
So their role today is to listen to the presentations and discussions, and as we've done with other meetings, staff will prepare a summary of the input that you give, and we'll present that to the board, and then we'll have the opportunity for the board members who are in attendance to add. I'd also like to introduce our co-facilitators. We are working with LRI, leading resources, to have an internal neutral third party to facilitate our committee meetings, which allows our staff members and presenters to fully participate. So pleased to be joined today by Karen Bloomer and Jane Harrington. Okay, so some program updates. Well, no, thank you. Our agenda first. So as you can see, our agenda, we have 4 very meaty topics to give you all a presentation about and get your input on. So we will be talking about our cost and market impact review regulations, which we posted on Tuesday of this week, and look forward to your input about those. We'll be joined by Margareta Brandt to talk about our draft APM, alternative payment model standards and adoption goals. We've had a subcommittee working with us, or an advisory committee working with us on that. Look forward to presenting and hearing your input. We also have issued draft regulations on THCE capture, total healthcare expenditure regulations, and look forward to hearing your thoughts about that. And then last but not least, the board will be adopting the first spending growth target in 2024. And so we have a presentation about spending growth targets and get your input on that. So 4 very meaty topics in a long meeting today, and look forward to your thoughts. Now I will go on to executive updates. So on this last day of Native American Heritage Month, I'd like to begin our meeting by reading HCI's land acknowledgement. HCI acknowledges that our Sacramento and Los Angeles offices sit on land stolen from the Miwok, Nisenan, Chumash, and Gabrielino Tongva peoples. We believe it is essential to recognize the historical truths regarding the government-sanctioned forced displacement, enslavement, and efforts at cultural genocide inflicted on these peoples. We acknowledge the resilience and fortitude of these and other Native peoples who continue to survive as cultures and communities despite decades of mistreatment. Cross-generational trauma, systemic racism, and historic discrimination have taken a toll on Native peoples, contributing to health disparities, a lack of access to healthcare services, and barriers for Native peoples to become part of the health workforce. We at HCI commit to evaluating our efforts in these areas to advance justice, rectify past injustices, and ensure historic wrongs are not repeated. In solidarity and allyship with Native peoples, HCI commits to being positive catalysts for change by disseminating actionable information to expose the lingering impact of past actions against Native peoples and underserved communities, by listening to tribal voices to guide us in eliminating barriers Native Americans peoples face in becoming part of the health workforce, and by revisiting HCI's programs, policies, and procedures to allocate state resources equitably in a manner that recognizes our responsibility to address disparities. So appreciate HCI's racial equity team that developed that and some of our other equity statements. Moving on to some project updates, I'll start with legislation and a few bills enacted that impact HCI. One of the most significant healthcare bills adopted in this last legislative session was Senate Bill 326, which recasts the Mental Health Services Act as the Behavioral Health Services Act, so broadens it to allow for treatment for substance use disorder and also to pay for housing. For HCI, SB 326 would allocate a portion of BHSA funds to HCI to administer a behavioral health workforce initiative. So the state is doing a lot to invest in the development of behavioral health workforce. This would allow additional funds for that important purpose. It will also those funds will be expanded if a related ballot initiative passes and then federal approval is obtained. So there's kind of a 3-part step to get to a rather significant investment in behavioral health workforce dollars. Additional bills that impact HCI, one was a bill expanding collection of data related to clinics. One to expand our hospital supplier diversity program, and a bill regarding seismic compliance milestones for some particular hospitals. HCI data and a report also contributed to a bill allowing critical access hospitals to directly employ physicians. So there was a pilot project with a sunset date that's now been eliminated in an exception to the usual ban on the corporate practice of medicine. And then very significantly, Senate Bill 525 will set a new minimum wage for those working for healthcare entities. So there are 4 different phase-in schedules for different types of entities based on their size, location, and payer mix. And HCI has a role in posting a list of the large healthcare employers with 10,000 or more employees, as well as hospitals with a high mix of Medicare and Medi-Cal patients. We're also charged with working with DIR, with the Department of Industrial Relations and DHCS on a waiver process for clinics. We think Senate Bill 525 represents an important focus on the lowest income workers in the healthcare arena and provides an important recruitment advantage. We're certainly aware that OCA will need to track these minimum wage changes, and also don't think that every new cost needs to be borne by consumers. So that is on the legislative side. On the healthcare workforce development side, really excited that we have neared completion on developing a new behavioral health role, the wellness coach. As part of the Children and Youth Behavioral Health Initiative, Secretary Galley had the vision for this new workforce And we've engaged a lot with stakeholders, most importantly with youth. And youth have told us that they want a workforce that's more diverse, that's closer in age to them, that's more diverse in terms of race, ethnicity, language, LGBTQ plus status, to provide them with support and skills training. So we're really, really excited to launch this new wellness coach role. We're launching today a new website. Maybe you've heard, we actually have some radio ads about the wellness coaches, doing all sorts of fancy outreach things that we don't usually do. A number of school districts have employed a similar role. Some of them have called them advocates or liaisons, but really, again, we know that there's a mental health crisis facing our youth, and we think this is an important profession, important role on the workforce ladder. There are a lot of we have peer support specialists, we have a lot of licensed mental health professions and not a lot at the AABA level. So we're excited about this role, but both being important in and of itself and also, we think, a step along the career ladder for behavioral health. So we'll be launching a certification process in early 2024, as well as employer support grants to provide funds to community-based organizations, schools, and other organizations that want to employ these coaches. So we're excited. We hope you are too. On the HPD, we know there's some really important synergies with OCA and with the healthcare payments data team. We had our HPD advisory committee meeting in October, and HPD presented on proposed reporting for 2024. Again, a number of HPD advisory committee members here. We are looking at our public reporting for 2024, including a focus on social drivers of health, additional pharmaceutical cost data reporting, as well as some reporting on hospital spending. The committee also discussed the expanded framework for non-claims data collection and provided their feedback. So Margaretta Brandt from our OCA team was attending our HPD meeting, and it's very much work that OCA and HPD will be doing together to develop the framework for collecting non-claims data. The HPD program is in the process of finalizing a third pharmaceutical cost visualization that will be released shortly, adding to the existing suite of public HPD products that we hope you are checking out and using, including our HPD snapshot and the HPD measures report. The data access and release regulations for the HPD program will shortly be re-released for a second public comment period. And we continue to actively work with our data release committee. So those are a few highlights in terms of program work at HCI. And with that, I will turn it over to Vishal Pagani.
Thank you, Director Landsberg. So as we do at every meeting, we've shown this slide at the prior AC meetings. We'd like to remind the committee about our slide formatting. We use a blue arrow in the presentation for areas that the advisory committee provides input or recommendations based on statute and other areas as requested by the board or OCA. And then on the next slide, I'll be providing an overview of OCA's 2024 board and advisory committee meeting calendar. So in the red, you'll see the monthly board meetings, and then in the blue are the quarterly advisory committee meetings. And we've tried to for all the advisory committee meetings, they tend to happen either the day before or the day after the board meeting. So these are the ones that are planned for now. We do have a note here on the slide that these dates could be subject to change, but for the most part, we do intend to have these meetings in the coming year. And then in the next slide, I'll be discussing the advisory committee member selection timeline. And so I know that it may seem kind of soon that, we've just had a few meetings with you, but we do have an annual process where new members could apply, and then members that want to continue could be reappointed. So this is just our annual process for member selection, and at the December board meeting, we'll begin discussion around this, around the 2024 advisory committee, a subcommittee of the board, and so on, and member selection criteria. And then that period between January to March of 2024, we'll solicit applications from those who are interested in joining the advisory committee. From March until May of 2024, we'll work with the board to deliberate and select new advisory committee members. And then in June, we'll announce new AC appointees. And then in September of 2024, we'll have our first AC meeting with any new members and reappointees. So, if some of you do have staggered terms in terms of your term may be expiring in 2024. So we'll send out information about reapplying and more specifics about kind of reappointment processes. So I just want to pause here if the advisory committee has any questions.
Are we able to kind of solicit people that we know that we think may be a good fit for this to apply for the advisory committee?
Yeah, it's similar to last year. We put out a call. We sent out a blast. So if you think there's someone that would be a good fit, you could pass it along. Yeah.
Just a quick question, Vishal. Curious why our meetings are so close in proximity to the board meetings, even particularly if they're after the board meeting. Where are our recommendations going, and how is that process formulated?
Yeah, so it's, if we could go back to the slide about the meetings. The way that this obviously doesn't show the content of what the board will be discussing in those months and what the advisory committee is going to be discussing, but whenever we do bring a topic before the board, sometimes it just doesn't work out with calendars where we could schedule the advisory committee meetings to happen before the board meeting. But to the extent that we will have a way to channel the feedback from the advisory committee. It just may not always happen. Like a good example will be when we go over some of the APM feedback, alternative payment model. Like it doesn't mean that the board's going to act on anything the next day. We may get your feedback in one particular month, but then we may not communicate it out to the board until another month. And that's the benefit of having more monthly, or the board meetings happening on a monthly cadence, that we have the opportunity to relay advisory committee feedback as well as other stakeholder feedback.
And just in terms of the split between the sort of January and April meeting, isn't the light's green?
Yeah, you might just have to speak into it. Yep, thank you.
In terms of that split between the January and April meeting, were there 3 meetings happening of the board between our meetings? That feels a little difficult for us to give feedback. And so just making sure that as we're planning that January advisory meeting and the April, that we're just being really intentional about the agendas so that we're spacing it across all of those board meetings.
Yeah, I think we hear you. The statute, as you know, does require us to have these meetings quarterly. The business of the board is such that we need to have the board meetings more frequent at this point, but we're certainly, we'll definitely be intentional about setting them. And that's part of why we're having you here for 7 hours today, to make sure we're covering all the key topics.
All right, if there are no more questions, we'll turn to public comment. We will now recognize members of the public for comments on agenda item 2, executive update. Please reserve comments on the other items for the general public comment period. To ensure equitable access to verbal public comment, we will alternate between members of the public present in this room and those attending virtually. Those in this room may line up at the podium. Those attending virtually who want to comment should click the raise hand button. If you're dialing into this meeting on the conference phone line and you'd like to provide public comment, we ask that you submit your comments via email at oka@hchi.ca.gov, or please join this meeting online if you'd like to make verbal comment. Please keep your comments to 2 minutes or less so we can hear from as many members of the public as possible. Please note that while the committee is committed to communication and transparency, committee members and staff will not be responding to public comment. Additionally, the committee may not discuss or act on any matter raised during the public comment period that is not included on the meeting agenda, except to place the matter on a future meeting agenda. We'll start with individuals here in the room at the podium and invite them to step up and speak. Seeing none stepping up physically in the room, we'll look at the virtual raised hands, and we're going to invite Janice Rocco to unmute.
Good morning, Janice Rocco on behalf of the California Medical Association. Just to add to the question and the comment from the advisory committee meetings members about the meeting cadence compared to the board meetings, there are times when an issue is brought before the board, could be brought before the board on an occasion prior to the advisory committee meeting. Then the advisory committee meets, and then the board might be making a decision by the next time the board meets. I feel like we don't know exactly how everything's going to play out over the next year, and it would be a good idea in my mind to have these advisory committee meetings at least a week before a particular board meeting rather than a day before or a day after, because there could really be times when you want the advisory committee's opinions on something that the board is then going to be discussing thoroughly the very next day, even if they're not making a decision, and they would benefit from knowing what the advisory committee had to say. So a day before makes it very hard to compile all the information and be able to articulate it at the following day's board meeting, and a day after makes it impossible.
Thank you. Not seeing anyone here in the physical room stepping up to the podium, looking to the virtual members of the public. I don't see any raised hands at this time. And so I think we're ready to turn to agenda item 3, cost and market impact review, CMIR, regulations update with Sheila Tatayan.
Good morning. It's been a while. Can you hear me okay? Great. All right. Well, we're back at it with CMIR. And so just want to go over today with you what's been happening with the process for the development of the regulations, where we are, and we'll go over some of the changes that have been made.
Sheila, excuse me, could you speak up or move the mic
sure.
a little bit closer? Thanks so much.
Okay. Here we go. Let's try that. How's that? That's what seems to be better. All right. So today we'll go over where we are in the process, what's happened to date, go over some of the specific language that's been changed, and take questions. Looking for my slide advancer.
To advance the slides, would you?
Yes, that's the one I want.
And staff can advance if you'd like to say. Next slide.
Oh, you're having trouble with it. Okay. Okay. All right. So I hear there's technical difficulties. If I can't advance, I'll just say next slide, please. All right. So as you may remember, we posted the first draft of our regulations on July 31st, and it had a written comment period of 30 days. We also held a workshop on August 15th. So We received 21 written comment letters at the end of August, and then at the public workshop, we did have 13 commenters who shared verbal comments, both in person and virtually. And we posted the comments that we received, so you can see those comments, the written comments, on our website. Then after we reviewed and considered the over 187 pages of written comments, we then made revisions and we posted the second draft on October 9th with another comment period. October 9th was the publication date on our website, and then October 17th was the deadline for written comments. We received 16 comment letters, which also interestingly totaled over 180 pages. And those are posted on our website as well if you'd like to see them. So we had a total of 29 different commenters. Some commented both at the workshop and then written comments, but the unique number of total commenters was 29. And we had comments from a variety of groups, from physician groups, health plans, hospital systems, consumer advocacy groups, unions and medical groups, hospitals, and nursing associations. All right. Yes, I do need help advancing the slides. All right, we made some changes since this last time I saw you in September. And so you can see them on the screen. Affiliation we amended to clarify that clinical trials, medical education programs, and other types of education or research are excluded from having to file. Healthcare entities, we amended that. There was a lot of comment on our definition of MSO as a healthcare entity, so that was removed. And then we clarified material change transaction, and this was an important one because we heard a lot of feedback about how we would potentially capture too many transactions. So we limited that to those actually we excluded transactions that are in the ordinary course of business. So we limited it to major transactions, not those transactions that would be in the regular course of business. And then we clarified the definition of transaction so that folks could understand that it was between a healthcare entity or one or more entities, and that out-of-state transactions may be subject to the filing requirements, and that OCA will review transactions that transfer a material amount of assets, control, responsibility of a healthcare entity to one or more entities. So the next slide these next few slides give you a little bit more detail so you can see the actual changes, and I won't read them to you. I'll let you take a look, but I'll highlight some of the significant changes. So in the definition of healthcare entity, you see that we did remove MSO, and then in number 3, we did clarify it includes parents, affiliates, subsidiaries, and other entities when they act as an agent in California on behalf of a payer provider or fully integrated delivery system, pharmacy benefit manager. Okay, so you have to be an agent, and then either govern or financially responsible for the healthcare entity, or that are subject to the control, governance, or financial control of the healthcare entity, such as an organization that acts as an agent of a provider in contracting with payers, negotiating for rates, or developing networks. Right, and then the number 3 item there, or in the cases of a subsidiary acting on behalf of another subsidiary. And this is because often when you see these transactions, it's a complicated relationship as to who's actually doing the transaction, who's involved, who's in control. So this was important to clarify. When you're acting as the agent, you're stepping into the shoes of that healthcare entity. And then we clarified the situations because our statute excludes physician organizations of 25 or under. Those are not considered healthcare entities. So we hope that we have clarified that in item number 4. All right. So if you are an physician organization of under 25, you would not have to file because you don't meet the definition of healthcare entity. But if you are a healthcare entity doing a transaction, regardless of the size, the healthcare entity, has to file. I'm seeing, looks like people understand that. All right, next slide, please. Okay.
Adam Donnery, go ahead.
Sure. Oh, sure.
It's just for my and the committee's clarification. We did remove the terminology of an MSO, but it does appear under item 3, subclause 2, that the function of an MSO essentially is just included right back into that without the name itself. Is that correct?
That's correct.
Okay.
So the initial draft defined an MSO as a healthcare entity. Right? This, we remove that, but the function of an MSO, you are correct, is included in the definition. All right, so on to the next slide. So for material change transaction, as I mentioned, we clarified that, and we put in specific language to exempt those transactions that are in the typical day-to-day operations of the healthcare entity. So if it's in the regular course of business and typical day-to-day operations, it's not a transaction that OCA would be reviewing. And then corporate restructuring. So if there's already control and it's really just a matter of corporate restructuring, those transactions are also excluded. All right, so the definition of transaction, we just clarified that a little bit to emphasize the transfer of control, responsibility, or governance of the assets or operations of any healthcare entity in whole or in part to another healthcare entity. And this really matches the language of this statute. And we noted that we are looking at transactions that will impact the provision of healthcare services in California, because that's really our function, is to look at transactions that will impact the market and bring transparency and inform the public. All right. Oh, go ahead.
Question
That's a
from
good
committee
question.
member. Please go ahead.
I'm just curious, the in part of this statement, does this mean you could have a tiny minority interest in an entity, but it would still trigger this transaction? Is there any materiality kind of threshold for in part?
Yes, there is. Later, as we define the circumstances for the transaction, we define change of control. So there is a materiality threshold of 25%.
Okay, thank you.
So yes, it couldn't be less than that. That would be really tiny in part. All right, the next slide, please. So the thresholds for filing, you may remember that the first part of the exercise in this test is who has to file. All right, so you look first if you're a healthcare entity, and then if you meet the requirements for filing. So we had the third provision in that was related to a HPSA, a health professional shortage area. And we realized that we would potentially capture transactions in a HPSA that we really wouldn't review, for example, dental. So we clarified that the HPSA is really just those medical and behavioral health care HPSAs. All right, and then the circumstances requiring filing, I sort of went over that already. Again, you have to be a healthcare entity joining, merging, or affiliating with another healthcare entity or when you're changing the form of ownership. And we added a 10-year look back because we've been studying what the FTC has been doing, and we're aligning with what the FTC has been doing. And you may have been reading in recent literature about the anesthesiology case. The FTC used to have a 5-year look back, but they're going to 10 years in their proposed changes, and so are we. And then again, to your question, I've highlighted that we changed the materiality for transfer of governance or control, and it's a 25% threshold. All right, the next slide. So this is what I was just mentioning about the first part of the test. So you go to this section and you look at this section, and if you meet the definition of healthcare entity, you look to see if you meet these circumstances, and there are 3 circumstances. So the first is whether the healthcare entity has annual revenue of 25 million or more, or owns or controls California assets of at least 25 million or more. That has not changed. That has remained constant. But we did clarify that it's California derived revenue. So when you look at the language of the regulation, there is a revenue definition. And if you're already reporting revenue to a regulator, we've matched the definition of revenue for them so that the calculation of your revenue is easier to do. And then the second is if the healthcare entity has annual revenue of at least 10 million or owns or controls California assets of at least 10 million and is a party with another healthcare entity that has 25 million. So it's 25. The second one is, are you 10? Are you doing something with a $25 million entity? And then the third, as I mentioned, is just a general, not tied to revenue, but are you in a primary care or behavioral health HIPSA? All right, next slide. So after you evaluate those thresholds, the next step is to look at the circumstances of the transaction. And here is where we made some fairly significant revisions. Our initial draft had 10 circumstances. We've now reduced those to 8 in an effort to really target what is material. So we worked on these 8 thresholds in terms of materiality. So the first one is very broad, and it is whether the transaction has a proposed fair market value of 25 million or more and concerns the provision of healthcare services. And if you remember when we talked about the definition of transaction, it's related to the provision of healthcare services in California. So you need to read the regulation in totality. Number 2 is the transaction is more likely than not to increase annual California derived revenue of any healthcare entity that is a party to the transaction by at least 10 million or 20% or more of the annual California derived revenue once it's at normal operations. 3, transaction involves the sale, transfer, lease, exchange, option, encumbrance, or other disposition of 25% or more of the total California assets of submitters or any healthcare entity in the transaction. So the 25% is the materiality here, because if you're encumbered, and I want to point out that we did get some questions about the use of encumbrance, that is in the statute. So to make specific the statute by regulation, we use the term encumbrance. So yes, if you're in debt 25%, we consider that significant and material. Number 4, the transaction involves a transfer or change in control, responsibility, or governance of the submitter in whole or in part as defined in subsection E. And that does go to your question because subsection E is the materiality provision of 25% for the change of control definition. All right, next slide, number 5. And this is a new one. You can see the way regulations, for those of you who are familiar, the new language is always underlined, the deletions are always strikeout. So number 5 is the transaction will result in an entity contracting with payers on behalf of consolidated or combined providers and is more likely than not to increase the annual California-derived revenue of any of the providers in the transaction by either 10 million or more, or 20% or more of the annual California-derived revenue, again at normal or stabilized levels of utilization or operation. So that is the new number 5. Number 6, the transaction involves the formation of a new healthcare entity, affiliation, partnership, joint venture, or parent corporation for the provision of healthcare services in California that is projected to have at least 25 million in California-derived annual revenue at normal or stabilized levels of utilization or operation, or transfers the control of California assets related to the provision of healthcare services valued at 25 million or more.
Sheila, we have a question from Sumana Reddy.
Sure.
Sheila, back to 5 there. I'm just curious about the more likely than not, and in terms of methodology, is this going from the current revenue of the organization that is being acquired? Because I see those situations where the acquiring entity then increases prices significantly. And how are you going to sort that out, right? It's really hard to do ahead of time, I imagine.
Well, these are the thresholds for reporting, and the hope is, all right, when we get these notices. So when we look at this, parties will do their due diligence and decide whether the deal is a good deal for them. And so they will be looking at what the consequences, what the hopeful outcome is, in terms of what value is it to them. So, for example, when we set this at 10 million or more, or 20% or more, that's the expectation. So that is the beginning point. If you're a healthcare entity and you meet those circumstances, and this is one of the reasons for your transaction, then you have to report to us. So it's a projection, and it gives us the opportunity to look at those transactions and then evaluate them, evaluate the organizations, see where the market position is, and see. So as far as sorting it out, we really won't know. We won't know if the expected outcome happens until after the transaction closes. But that is why we require a fair amount of detailed information to be submitted with the notice of transaction. So, for example, we require term sheets, we require financial statements, we require full descriptions of the organization so that we can at least see where they are now, see what the expected outcome of the transaction is, evaluate it, and inform the public. So I hope that answers your question.
Sheila, do you want to mention the valuation documents as well?
Yes, exactly, the valuation documents. Any other questions on that?
Joan Allen, please go ahead.
Can you describe a little bit how revenue is calculated? Because I see that in the definition of revenue, it varies pretty considerably for the different types of entities. So can you just speak a little bit to the thinking around how revenue is being defined? Because as we're changing to the California derived revenue, it changes some of that. For example, I'm struggling to see how things like some of the non-operating revenue would factor in, and it looks like that may be included for plans but excluded for providers, and then some of that California derived, so that just is a little bit of a tough term for me. And so can you talk a little bit more broadly about how these changes are going to impact what revenue is going to count?
Sure. So you may remember fundamentally with our statute that when OCM wants to collect information, we are to alleviate the administrative burden. And so we are to collect information that aligns or is already reported to existing regulatory agencies. So when we looked at collecting revenue information, we thought, who's already reporting their revenue and to whom are they reporting it? So for example, plans have to report to the Department of Managed Healthcare. HCI collects hospital financial data. Skilled nursing facilities have to report their information as well. So we tried to match those situations where entities were already reporting their California revenue to a California regulator to make that burden a little bit easier. And then we can verify that information because it's already collected by another entity. Go ahead.
Well, that makes complete sense. And I'm looking at things like the provider reporting that's already done to HCI. There are fields for things beyond just patient revenue. There's also other operating revenue, non-operating revenue, and those aren't included in the definition of revenue. And I would encourage that they be included. They're already reported, so it's not a data burden. It just gives a much more complete picture of the financial standing of the entity.
Thank you. Thank you. That's a good comment. But I would say that even if it's not required for them to report with the notice, we would still get the information. And through sources that we could get that information. Are you talking about information that's not already reported to other entities?
Well, also it would determine whether they've met the threshold. So if you have an entity where they have multiple sources of revenue coming in and the threshold is being set based on just one of those sources of revenue, then an entity that is large enough to have met the threshold, if we were using total revenue, would fall under.
I see what you're saying. You're saying that if we exclude certain categories of revenue, they might come under the actual revenue threshold. Yeah. And so what I was saying was when we get the information from the healthcare entity, we would look at other sources of revenue that we could access and try to make that determination.
Okay, that doesn't seem to be how the definitions work in the current version. There'd be the understanding, but it wouldn't go toward whether they've met the threshold.
I think I see what you're saying in terms of them understanding what they have to report and what the filing requirement is. So thank you. Anything else?
Carmen Comsty has a question.
Thanks, Sheila. And you know, just to kind of put a point on what Joan was saying. You know, I know that when you're looking at net patient revenue, there are some hospitals that ultimately will report zero net assets, which is a problem. You know, and there, I know that Kaiser Foundation hospitals often report zero. So what does that mean in terms of the material transaction requirements? Because if they're reporting net patient revenue at zero, does that mean that they're exempted from material change transactions? And that's why it's important to look at the total annual revenue, so that we don't have this imbalance of you know of hospitals being able to, and other facilities being able to kind of argue that they're not subject to the material change transactions because of where we're looking at in terms of their reported revenues.
It's a 3-year measure. So it's a 3-year measure of revenue. So it wouldn't be just a single year. So for example, if zero was reported, for 1 year, we would have a 3-year average because that's the requirement for reporting.
Barry Arbuckle.
Oh, thank you. I just wanted to make sure I understood that last exchange. I don't know what Kaiser reports. I'm trying to figure out how any hospital could report zero net patient revenue. I could see zero net patient income, but net revenue is just unfathomable. But it might be a uniqueness of the way Kaiser reports as a 3-headed, you know, entity. So that may only be relevant to Kaiser as far as I know. I know no hospital in the state that could possibly report zero net patient revenue because they wouldn't be in business. So I just want to make sure I understood it. Are we talking income or revenue? You're talking revenue.
I'm talking revenue. Yes. Net patient revenue. Any other comments or questions on that? Go ahead.
Yes, Adam Doherty.
Just one additional question for clarification. I know there was confusion around software and EHR, whether they were considered, you know, purchases contracts as regular course of business, as they are defined essentially as healthcare entities. Can you clarify that? Was that considered, and how is that being defined?
Yes, and that was a good question because as we know, there's a lot of investments in technology, and we have actually defined technology as part of healthcare services. So I can appreciate the confusion. So if it's a transaction that's related to supporting your regular course of business in your day-to-day operations, you would come to us and you would say that. That's the argument you would make to us. This technology is to support our day-to-day operations, and we're renewing a contract, or we're amending a contract, and so you'd come to us and make that, give us that information, and that would lead us to the conclusion that yes, it is in the regular course of business. So I can't give you a blanket rule, but it's really up to the entity to determine for themselves and then come to us and explain why this technology transaction is in the regular course of business, supporting ordinary day-to-day operations. Is that helpful? Looks like there's another question.
Stephanie Klein or Stacy Rontis?
In that last example, would it require the complete filing or would it just be a conversation?
So in the last example, if you came to us and you said, we have a proposed transaction with this technology vendor and we wonder whether we have to file, that's an email or a phone call. And then you tell us what you think it is. And then we say, well, that's really a material change and we think it goes beyond your ordinary course of business. For example, a new telehealth contract, right? That would, when you had no existing telehealth, that would be something new and not necessarily in the ordinary course of business. So that is email to us, perhaps a phone call, a back and forth exchange.
Adam Doherty?
So in a sense, then this is more about everyone learning about what the process is, seeing that played out in certain examples and understanding in a more informal process as opposed to filing.
Exactly. Remember, these are our inaugural regulations, so we have to start somewhere. And so we expect a lot of, use of the email, phone calls, and we welcome that because it is a labor intensive exercise to file with us. We recognize that.
Stacy Rontis?
Sorry to belabor this, but is it purchasing a telehealth company or creating your own?
Well, so then you go to your lawyers or your your outside lawyers, in-house counsel, and you look at the facts of the situation. And so, how are you getting funding to purchase your own, right? That's an encumbrance. So that would be, you might maybe not doing it with another entity, but there might be some financing of over 25%, 25%. You might be encumbering your assets 25% to do that. So again, it's looking at the totality of the regulations and answering those questions. So, and they are very fact specific. We could probably spend a good, yeah, exactly. We could probably spend a good hour going through, well, what about this and what about this? And so that's facts to law. All right, any other questions? Okay, I want to point out on the next slide, if we can get to number 7 and 8, these were revised and we had some thresholds regarding serial transactions, but we made them clear. So we have these last two, 7 and 8, regarding serial transactions and roll-ups. So it's not uncommon in the M&A world for entities to do a series of transactions where they just do small ones at a time and they fall below the dollar reporting threshold. And then suddenly they have market power and no one's really been watching that. So that's really what number 7 is about. And you'll notice that number 7 talks about the same healthcare entities or related healthcare entities. So you can think about those hospital situations where one entity may purchase another part of a hospital system. That's just one deal, and that deal might fall below a threshold. Then they purchase another one, and the transactions amounts might be under our thresholds, but they're doing it piecemeal at a time. So that's the serial transaction scenario. And so we try to make number 7 clear so people would understand that when you do that, we're going to treat those series of transactions as a single transaction. And then number 8 is about the roll-up. This is where someone is acquiring the same type of healthcare entity who performs the same healthcare services. I'm going to buy 1 SNF, 2 SNFs, 3 SNFs, and suddenly I have a dominant place in the market. And as I mentioned, the recent anesthesiology case that the FTC is looking very closely at and pursuing and has been in the news. All right, next slide. So we removed some duplicative and potentially burdensome filing requirements in response to the comments that we received. So we did tighten that up. And then we also clarified the confidentiality provisions because we do want to give submitters the ability to request confidentiality. So there will be a process for that. Um, and there will be clear forms for that in our ePortal system. And then we did work on an expedited review process. It was very narrow in our first regulation. It's still fairly narrow, but we've refined the clarification of that and the process. And then we did reiterate, it is in statute, but I think there was some confusion or some question, but the director does have authority outside of any transaction. So no transaction has to be part of this, but the director can order that a cost and market impact review be done. This next slide is significant because we did receive a lot of comments. We do recognize that the process is long. So we did shave off some time here. So healthcare entities will submit notices to us, and the statute calls for a 60-day period for OCA to decide whether to do a cost and market impact review. So what we've done is we've said, we will let you know within 45 days of whether we intend to proceed or not to a CMIR. But if we're going to CMIR, we're going to take the full 60 days because remember, we've also put in regulation that if the healthcare entity is going to be subject to a CMIR, there is an appeal process. So if you're going to go through a CMIR, you'll be notified in 60 days with clear reasons in writing as to why, and then there will be a time to request a redetermination of that. And so that's why OCA does need the full 60 days. But if you're not going to CMIR, OCA can tell you within 45 days or sooner. And we did clarify the process for tolling the timelines. This isn't just abstract. It's really when we need additional information, because what we have heard from the federal government, from our sister agencies, from everyone who does this merger review work, some of the hardest times to get the review done, or some of the most challenging parts of getting the review done, are getting the information. So we really want to incentivize folks to give us the information that we need, which is why we need to toll the time frame while we're waiting. And then finally, there was a period from the time of issuing the preliminary report and receiving public comment to the issuance of the final report. It was initially 45 days, but we've shortened that to 30. So in total, we shaved off 45 days of the entire process. So this last slide is just a timeline looking ahead. So as Director Landsberg mentioned, we did post our advance notice of emergency rulemaking on Tuesday. That begins a 5 working day period for our office. We wait 5 working days, and then after the 5 working days, we will be submitting our regulations to the Office of Administrative Law. Commenters can comment. The comment period will end December 11th, I believe, if we're counting the days correctly. Vishal's going to check for me on that. We were calculating because we were saying, when will we post? And so I believe the end of the comment period will be December 11th. And then commenters should submit their comments to both the Office of Administrative Law and OCA. That's actually required. And then once we submit to the Office of Administrative Law, they have a 10-day, not 10 working days, but a 10-day period to review and approve. They can, of course, come back to us with questions. So sometimes but it has to be within the 10 days. So we intend to finalize the regulations in December. We are in the process of testing our ePortal this week. So we intend to be ready to begin accepting filings on January 1st or sooner. You know, if folks want to, we'll let you know if we're ready to flip the switch on our ePortal sooner. Any questions? Yes.
I see Joan Allen's hand.
One place, first off, very excited that that you're getting so close to being ready to flip the switch. That just overall fantastic. But I have a question on one place where the regs still offer a fair amount of leeway for OCA to make determinations on a case-by-case basis is on the confidentiality provision. And we've seen from other regulators a tendency for entities who are requesting confidentiality for all or part of a document to default to asking for that in perpetuity. And that makes it very difficult to go back after the fact and understand much later, once the purpose for that confidentiality is long gone, to be able to understand whether that filing is appropriately confidential or the impact of what's been happening related to that filing. And so would encourage, as you are looking at that flexibility, to be very judicious with in perpetuity confidentiality grants, and would just like to hear a little bit about how you're thinking about how OCA will determine how long is appropriate to hold a document confidential.
So I would encourage you to look at, and you probably already have, but to look at the confidentiality provisions. We make it clear, first off, at the very beginning, if it's already publicly available, we don't say it this abruptly, but basically don't ask for confidentiality if it's already publicly available. And then we do require that if you're going to ask for confidential treatment, you specify the time period for the confidentiality, because as you know, and as you're acknowledging today, sometimes documents only by law are required to be confidential for a certain period of time. So by law, sometimes things will be out in the public domain. So as soon as, you know, the request has to align with the law, you know, we will be looking at that. Some things about in the mergers and acquisitions world always remains confidential. For example, it's very hard to get information about the actual dollar size of a transaction because that typically remains confidential in perpetuity. So
that actually raises a really, as I saw that the valuation was added to the things that would be deemed eligible for fairly automatic. And yet I see press releases all the time with the valuation of a transaction.
yes.
And so how will those things interact?
If they're going to announce their dollar deal in the press release, then don't come to us and ask for confidentiality. And that's what we made very clear from the start in saying if it's already publicly available, it won't be eligible for confidentiality. But there are many deals that where the dollar amount years after the fact, you'll never know. So if you look, for example, at PitchBook, that's a software program. There's many software programs. If you try to actually see the dollar amounts, it is very challenging. Some you can get, many you cannot.
And in terms of things that are, they say, oh yeah, we're going to keep this confidential. And then 6 months down the line, that valuation is out in the public. Will that then trigger the ability to get at not just that number, but also the documents that go toward the valuation?
Okay, here we go again. No, that's okay. No, these are good questions, that they're always facts to law. So it's going to be a case by case basis, as you say. So if you look at our regulations, certain documents are treated confidentially that may go into the valuation. And that's really common in the M&A world as well. So, you know, this is where the in-house counsel or the lawyers come to us with the request for confidentiality, and they have to back it up with law, for example. So there are trade secrets, right? And if they can show us that it's a trade secret under the law, then that request would probably be granted if they can show us that. So again, each of these situations is very fact specific. So using that trade secret example or some other like valuation discussions, if they can show us that there's a law that requires confidentiality for that, we will consider it. And so while you may end up seeing the dollar amount of the deal 6 months later, or a year later, that doesn't mean that the discussions leading up to that or information leading up to that is also automatically open to the public. So a good measure would be, is it available to the public now? Does it become available to the public? Then really there's no reason to treat it as confidential.
We have a hand from Tam Ma, committee member Tam Ma.
Hi, good morning. I was wondering if you can talk about, you mentioned like the e-filing portal will be ready by January 1st. If you could talk more about mechanics of what you're planning to right now to prepare for the notices that will begin to be submitted at that point, and like staffing and other logistics to review the notices that are coming in and make the determination of when they go to whether they go to CMIR. And then a second part of my question is really about, how do you plan on kind of tracking, the number of notices that come in, how many are going to CMIR, and then ultimately how long the process takes, so that we can kind of understand how this is all going as it is being implemented.
Sure. So we're very excited about our system. Um, it's being programmed in the Microsoft Dynamics platform. So users of Microsoft, which many of you are on Teams and Word and all of that, will find it familiar. So it's a Microsoft Dynamics, actually customer support system. So we use something very similar at HCI for grant applications. So basically, if you're going to submit a notice to us, you would go into the system on our website, register, and then your registration would be confirmed, and then you would basically be filling out a form. That's the notice, and each field will ask you for certain information, and then certain other documents will be requested on the system as well. And so they really are aligned. We've built the system to match and flow with our regulations. So that's how we will do that. And so as we receive the notices, the system will capture them. So we will have a record of all the notices received. We've structured the system so that there's the notice part and then the supporting documents part. Because you remember, what OCA will make publicly available is the information in the notice. The supporting documents won't be publicly available unless OCA determines that the transaction needs to go to a CMIR. And on our system, when people log in, there is a reminder pretty much on every page of the system that the information is public unless they request confidentiality. So that's the first part of the system. We'll receive notices. The system will track it. We have running clocks built into the system too for the time frames, and our staff will be utilizing that system to gather the information and conduct the review. And as far as staffing, you can imagine that we are staffing up, and we will also be using expert consultants as well to assist us with the review.
I'd like to add, at the board level, there's also been interest in tracking OCA's progress and in terms of the number of days to review a notice, and so some type of public reporting in terms of how fast we're reviewing the notices. And we are taking a look at that too, to see how we could communicate information out on, given that the board also is interested in, are we taking the full 60 days, or just to get kind of a flavor of the various types of transactions and how long is taking, and increasing some of the transparency around kind of what we're looking at. So more to come on that issue as well.
How are we doing on time?
We're a little behind, but these are important questions and comments, and we'll move to public comment as soon as we're finished with any committee questions. Anthony, Wright, did you have a comment?
Yeah, so just first of all, just appreciate the work on this. I think this is really important. We've had a lot of transformation in the ownership structures of our healthcare system and without a lot of visibility to it. And so I think this will provide it necessarily. I also appreciate how the revised changes have been responsive to comments of my organization and other consumer advocates, including on the clarity on being able to look at not just transactions, but also situations where there already is a market failure or problem in a situation. We've talked about Monterey and other places, and I think that's important. We appreciate that you're also responsive to some of the concerns about timelines, and from the provider community, I just want to say that the shortening of the timeline with regard to the time of the end of public comment and the final report to 15 days really does put a burden on the department with regard to being responsive to that, to those comments in terms of issues that are raised, in those short 15 days in a very serious way in order to be respectful to those comments and to be responsive to them. And so I just, like, as you mentioned about staffing up, we hope that that is part of the calculation, that as you try to shorten these timelines, you have the resources and ability to be actually responsive to issues that come up from the public and in other situations. And so, but overall, we appreciate the direction and having this new insight and visibility in place in the new year. Thank you.
Thank you.
Okay, seeing no other committee hands, we will now turn to public comment, and we will begin with virtual members of the public who wish to comment on agenda item 3, the CMIR regulations update.
So Andrew, we see your hand raised. You can unmute and go ahead.
Yes, Andrew Demetrio from the Hush Blackwell law firm. Just a question about
Andrew, we can't hear you any longer. All right, for the record, it looks like Andrew is no longer in the virtual meeting. We will continue public comment and see if he can rejoin. Going to individuals in the room, if you'd like to step to the podium.
Ben Johnson with the California Hospital Association. We'd like to just comment quickly that the prior revisions of the draft regulations did move things in the right direction, most importantly by exempting the transactions in the ordinary course of business. And so for that, we do thank the office. And this latest version of the regulations do take some further steps, shortening the timeline, clarifying definitions of revenues, ensure they are consistent with how the office more broadly will be looking at regulations such as under the spending targets. We still are concerned that the process will have significant negative impacts on hospitals' ability to provide clinically integrated care, and that they could overburden the office as well, given the low materiality thresholds, which will only reduce in real terms over the next few years due to there being no inflationary adjustment. Also note really again that we do find the definition of control is out of line with how it is commonly defined, given control would typically be conceived as having 50% or more voting threshold and so forth, so the ability to make those decisions. And then finally, that certain of the circumstances requiring filing do not specify what a material amount or percentage of assets that must be transferred, such as by instead specifying revenue increase thresholds. And so we have concerns that that is not consistent with statute. Thank you very much.
Thank you. Returning to the virtual room, Andrew has been able to rejoin us. Andrew, you should be unmuted on our end. Please go ahead.
Yeah, yes, I am unmuted, and thank you. A clarification question with regard to the provisions on roll-ups and on serial transactions. I understand that these regulations would then bring into reporting a transaction that in and of itself might not be reportable, but because of a series of transactions, it passes the threshold. The question I have is, in reviewing this and determining whether a CMIR is appropriate, will OCA be looking only at the transaction, the immediate transaction that is triggering the reporting requirement, or will the CMIR look back at all of the transactions that have occurred within the prior 10 years in making its evaluation? Because theoretically then the CMIR could have recommendations that then would potentially require the unwinding of transactions that were done years earlier. And I want to know what the thought is on the focus of the CMIR analysis in this situation.
Thank you, Andrew. Your comment and question are noted in the record. Moving back to individuals in the room, please step to the podium. Seeing none at this time, moving back virtually. Noting for the record, we have roughly 70 attendees virtually attending. Seeing no hands raised at this time, that concludes public comment.
We'll move on to agenda item 4, draft alternative payment model standards and adoption goals. And we'd like to welcome up Assistant Deputy Director Margaretta Brandt.
Hi, good morning, everyone. Good morning. I'm, again, Margaretta Brandt. I'm the Assistant Deputy Director for
Margaret, I'm so sorry to interrupt. If you could bring the mic closer to your voice.
Checking again. Is that better?
Maybe if you could even just pull it towards you a little closer.
Okay. So today I will share draft alternative payment model standards, definitions, and goals with the group. And these recommended standards, definitions, and goals have been developed with OCA's investment and payment work group, also informed by sibling department feedback and informed by subject matter expert and stakeholder interviews. So if we could go to the next slide. So I wanted to just begin our conversation by centering on the work of the team in terms of promoting a high-value healthcare system. So we, OCA, have 5 focus areas for promoting high-value health system performance: primary care and behavioral health investment, alternative payment model adoption, quality and equity measurement, and workforce stability. And across these 5 areas, the goal is to reorient the healthcare system towards greater value with the vision of creating a sustainable healthcare system that provides high quality, affordable, and equitable care for all Californians. And today, our focus of discussion will be on the alternative payment model adoption goals and standards. In the next slide, I wanted to share just a reminder about the work group that we have convened to support these work streams, especially primary care and behavioral health investment and the alternative payment model efforts. This multi-stakeholder investment and payment work group supports these 3 work streams, and the purpose is really to get feedback from a variety of stakeholders across the healthcare system to help us develop recommendations for these areas. And I really want to thank work group members for their extensive input and feedback on the APM standards and implementation guidance and the goals that we'll be presenting today. So in the next slide, I'll share some key work group discussion topics for especially focusing on alternative payment models that we've focused on. So some examples of the questions that we've been considering in the work group and we'll kind of flesh out today are: how can, detailed implementation guidance support healthcare entities in trying to implement the alternative payment model standards? How can the OCA APM contracting standards and implementation guidance support improvements in health equity? Should OCA require APMs have a link to quality to count towards our APM adoption goals? And then what are the trade-offs for the various ways that we could structure alternative payment model goals? So now in the next slide, I'll turn to our statutory guidance and requirements related to alternative payment models. So just on the slide, you, I think, have probably seen this before, but essentially the work for alternative payment models requires OCA to focus on 4 components. One is to move more payments from fee-for-service based payments to alternative payment models and measure this movement of payments to alternative payment models. 3 is to set a statewide goal for the adoption of APMs, and these goals could be based on a percent of members, providers, or percent of payments flowing through alternative payment models. And then 4th is to adopt contracting standards that healthcare entities can use for alignment with other state initiatives and to promote quality, equity, value in alternative payment models. So on the next slide, to meet these statutory requirements, we in the work group and internally have focused on 3 work streams. One, of course, is to develop the APM standards, and these standards aim to serve as best practices to guide healthcare entities in developing contracting terms that promote equitable, high quality, and cost-efficient care. And the next work stream is to define what we mean by alternative payment models. So these definitions serve as a framework and descriptions of the criteria for alternative payment model arrangements. And they also help us identify what counts towards our goals for alternative payment model adoption. And then, of course, the last work stream is to set these goals for alternative payment model adoption. On the next slide, we have used the following process, and I think you also have seen this slide before, but just as a refresher, in our initial stages of the process, we gained input from our work group, from stakeholder interviews, and from our fellow sibling departments. We, brainstormed ideas. We developed an environmental scan of the current state of APM adoption nationally and in California, and then also identified available data and reviewed it. And then we use what we learned from that first phase to draft recommendations. And this is where we are today in the second phase of this work group, or in this work stream. So we're incorporating your feedback and feedback from the investment and payment work group and sibling departments in our draft recommendations. And then we will also take these recommendations to the board based on your feedback and the feedback we've collected so far. And in the next slide, just have an overarching timeline. So today we'll focus on APM standards, definitions, and adoption goals and getting your feedback on these. And then we'll work to incorporate the advisory committee's feedback and then bring and refine them more, bring them back to our investment and payment work group to debrief, and then eventually bring proposals to the board in March for review, and then again debrief in our work group, and then bring a recommendation for board adoption to the board in June. On our next slide, now we'll kind of shift and get into our proposed draft APM standards and implementation guidance. And on the next slide, this again is the statutory guidance related to the standards. So we really think of this as additional guidance that guided how we developed the alternative payment model standards. So the statutory language focuses on facilitating multi-payer participation by leveraging best practices and encouraging flexibility. It requires alignment of metrics and a focus on protecting against unintended consequences of alternative payment models, and also recommends or requires that the standards reduce administrative burden through alignment across states, payer, and national programs. And we think of these as a set of principles that really guided our APM standard development. And on the next slide, this slide outlines our approach to the alternative payment model standards and implementation guidance. And we've approached the standards as best practices for contracting decisions that are common across alternative payment model arrangements. And the purpose is not to develop standardized contract terms or language, but rather to encourage alignment across current and future APM contract arrangements. And then the implementation guidance, which supplements the standards, provides specific actions or examples related to the standard that may be helpful for guiding, further guiding healthcare entities in implementing the standards. And while we strongly hope and expect that the APM standards and implementation guidance will be used broadly, at this time, OCA does not have authority to enforce the standards, but we will monitor their adoption and look to promote them as much as possible. So
in the next slide, this is our vision for how we can promote and use the standards. So we're this is our current thinking about how we could promote the standards and track their use. So the first milestone we've proposed here is for stakeholders to endorse the standards. So having stakeholders commit to using the standards to guide their contracting efforts. And then the next milestone is, of course, that this adoption or endorsement of the standards promotes alignment across alternative payment models and makes participation in APM arrangements easier for payers and providers. And then our last milestone is the most important. What we're really looking for out of alternative payment models is for improved outcomes, improved health outcomes, higher quality, more equitable, and more affordable care. So that's what we're hoping that these APM standards will promote. So with all of that background, turning to our first 5 alternative payment model standards, we're proposing 10 standards with associated implementation guidance. Again, as I mentioned, these standards were developed with the investment and payment work group and also with feedback from a variety of other folks, including our sibling state departments. So as we develop these standards, just a little bit of context that we received feedback that the standards should explicitly state that APM should result in improved affordability, quality, and equity, and really realign financial incentives to promote prevention and upstream healthcare services. And then there is also support that the APM models be linked to quality and also be budget-based. And there was support for alignment across APMs in terms of model design across payers and performance measures, and support for the models to really promote the use of and support the use of interdisciplinary primary care teams. So these are the first 5 standards. So I'll briefly walk through them, and then I'll also mention that in your handouts and also in links in the presentation, you have the full set of standards and implementation guidance. So 1 is to use prospective, budget-based, and quality-linked payment models that improve health, affordability, and equity. 2 is to implement payment models that improve affordability for consumers and purchasers. 3 is to allocate spending upstream to primary care and other preventive services to create lasting improvements in health, access, equity, and affordability. 4 is to be transparent with providers in all aspects of payment model design and terms, including attribution and performance measurement. And 5 is to engage a wide range of providers in alternative payment models by offering models that appeal to entities with varying capabilities and appetites for risk, including small independent practices and historically under-resourced providers. And then on the next slide, we have...
Margareta, I'm sorry, David Joyner has a comment.
Yes.
Yeah, I have a comment. Do you mind going back? Thank you. This is a very good start, but I worry about a significant issue that is not mentioned here at all, which is that an APM means a transfer of risk from a health plan to a provider organization of some kind. And I think the thing that's not here that's really important is the notion of it being actuarially sound. So I worry that as you try to set standards for more patients and more providers being in APMs, the potential health plan unintended consequence may be that there's a bigger push to push more risk down to providers that's not actuarially sound. So I think you have correctly here, you've said you're trying to implement payment models that improve affordability. I also think it needs to be economically sustainable for the providers who are taking the risk and actuarially sound. The other thing I'll mention is that speaking as a provider who gets involved in contracting and taking risk from health plans, the big issue we have about transparency is not just aspects of the payment model design, but transparency about the nature of the utilization that we're taking on, the history. And I would really encourage that for health plans, they need to be held to very strict standards around being completely transparent about what risk is being taken on in a model like this. We often find that that's not the case.
Thank you for that feedback. Great feedback. And I will also note it's in a footnote in the full set of standards and implementation guidance that we also note that, you know, any providers taking on risk are also subject to DMHC standards as applicable. So, you know, these standards are not intended to obviate any need for being compliant with DMHC standards for risk. But that's we can definitely consider that addition. Thank you. So I think we'll move on to standards 6 through 10. So these standards 6 through 10 focus more on addressing inequities and improving technical support to and the capability of providers. So a theme we heard through our work groups and other feedback is that really the need to acknowledge that the collection of demographic data should be improved upon and used more broadly in across our implementation of alternative payment models and how we are providing care, and then also potentially used to adjust payments for the purpose of addressing health-related social needs and inequities. So standards 6 through 10 aim to incorporate these themes and are as follows. 6 is to collect demographic data, including real SOGI data to enable stratifying performance. 7 is to measure and stratify performance to improve population health and address inequities. 8 is to invest in strategies to address inequities in access and outcomes. 9 is to equip providers with actionable data to inform population health management and enable their success in the model. And then 10 is to provide technical assistance to support new entrants and other providers in successful alternative payment model adoption. So I think if we want, we could pause there for questions, or we can keep moving on.
Excuse me, Carmen Comsty.
Yeah, sorry. I think just generally, you know, with APMs, I think I know that there's standards in here to say that they need to address inequities and to measure the stratification of you know, improving access for different populations. I think the opposite also has to be in these standards, which is that the APMs aren't causing inequities, and that they're not placing, you know, I think kind of putting a more less technical take on what David was saying is that, you know, we want to make sure that the APMs aren't inducing providers to cut care. And I think that's really important here, that we're not making the assumption that APMs will actually result in high quality care.
Yeah.
And I think that's not necessarily, you know, I think that may be the intention of some of these standards, but I think that's really important to put out there. And then also another point that I think, you know, needs to be discussed when we're talking about APMs, it's the use of algorithms to meet the APMs that are out there. We know, I mean, many of you know probably about the algorithmic bias from the total healthcare cost, hospital cost algorithms that were out there that have been studied highly by a lot of different entities. You know, there's a review by the FTC about these. So I think that also needs to be there, like what tools are being used to implement APMs, and does it cause inequity? So I think those are really important to put in here.
We have in implementation guidance 7.3, we have recommended that you know, the APMs, these standards be implemented with measures that monitor for unintended consequences. So you know, like not providing appropriate or necessary care. So we have a implementation guidance related to that to support that, but we can also further look into adding to that and addressing potential algorithmic bias.
I know we've got comments from Sumana Reddy, Carolyn Nava, and then Stacy Herontas, and Barry Arbuckle. So Sumana Reddy.
Thank you. APMs go back long enough that I just found some files realizing Medi-Cal managed care I was involved with 22 years ago in our county. And so perhaps I'm the person here who has been most wrangling with how this works on the ground, all the nitty gritty of it, and I just don't even know how to summarize my personal and practice experiences with these models. I think, as we try to look at how primary care has been under-resourced, and as I work so hard to attract new clinicians into my model of practice, one of the things that I've learned and seen increasingly over these last few years, as we now have 4 Medi-Cal, Medicare, and 2 private payers. And, I've staffed up, lots to say. Ultimately, the Medicare has been the most effective for us in terms of significant payment that allows us to keep our staff motivated to do these things. So it creates this self-fulfilling need to address these metrics and this particular model in a way that makes primary care sustainable on the ground. One of the major learnings for me has been, and I'm not sure if many of you see this, that large integrated models have so many more complex incentives to manage. And when we're looking at how do you support the existence of primary care, one patient, one clinician in a room, having the simplicity of my model in which I can care about the patient, do what's best for them. And I always talk about the multiple agendas, what that person has come in, what their perceived need is, and isn't that what should be primary? Then we have our extended other needs and extended needs for support to understand how our healthcare system is exploding costs because of very legitimate and exciting growth, whether it's molecular genomics or other areas that we all need support to understand to do what I do best, whether it's the simplistic sort of, this is why you don't need an antibiotic, this is the education to not go to the emergency room, all of which feeds into the, minimizing cost. But minimizing cost, which has been my entire career concern, is now becoming incredibly sophisticated, right? So when we talk about the bigger picture, it's that minimum primary care spend, right? Getting that bucket higher in a way that supports care, that if that patient has that relationship, I just want to frame it that way first, then all these other good things are going to happen that are parallel to and potentially in support of this model, but this model is not the whole thing, and it's just a model, like meaningful use was a model, right? And the unintended consequences are potentially high there. So, I'll have comments when we go into some of these other areas specifically, but I wanted to kind of throw out that broader framework. The need to do this is existential to attract new clinicians, and so I'm so grateful that all this work is going on. And then how it's done, the details, I could just give you volumes around how it can work better, how it can be harder. And I'm less concerned now about myself burning out. My staff are there because they love seeing patients. And I can't put them to 3/4 paperwork, right? It's very interesting to figure out how do I keep motivating them when we're all trying to figure out how not to have it be ticking boxes. So I'll stop there for now.
Simona, could you elaborate on what you meant by Medicare is the most effective?
We are a part of an MSSP shared savings ACO with the appropriate technologic support data provided to us and improved workflows, which I also work as a medical director in California to support other practices doing this. I go into those practices and help them with the ideas and workflows that partly come from the organization I'm working with, partly work that I've done myself over the years. This work has been leveraged in a way that's been far more effective. Unfortunately, I've seen our Medi-Cal managed care not be able to keep up with the data. Was wonderful, and I've respected them so much over the years. And I think now we're falling behind where the data comes to us in such a delayed way, which is really concerned to see the 6 to 9 months. because you don't have an opportunity to correct for that year if you don't get the data until way later. And then you have to go and submit corrections in a very clunky portal. This is happening with some of our private payers as well. So that's what I mean by staffing up, is that we've had to actually increase our staff to deal with this work. And then there is a gamification because you can't count on the additional revenue, right? Sometimes it works, sometimes it doesn't. And I could explain some, and often that is factors completely out of our control. And when you're talking about the, we've been working hard to understand our local Monterey County increased usage in the emergency room. We have not been able to get to the bottom of the analysis. And then someone threw out, well, maybe it's because most of your patients are farm workers and Spanish speaking. Well, it's an easy explanation, but we still don't actually understand if that's true. So you can get all this data, then to get to another level to help us with a technical understanding to do better, to provide that care better. I've been asking for that for 23 years. Okay, you're telling us that our kids go to the emergency room. Help us in real time. So to answer your question also, the Medicare piece, we do get that data in real time now, which we don't get for any other payer. That has made a massive difference. My staff are calling when a kid hits the emergency room the next day, or anybody hits the emergency room, because we're doing this across payers, even though not all payers, we don't want to distinguish by payer. Okay, so all those workflows are now across everyone. And our kids are now, they know they would rather come in to see us. So we've done so much to be accessible, but we don't necessarily, and not every practice is doing this. This is why I'm so passionate about helping other practices, because we are trying to be that test model, if you will, to see how all this works, right? And we don't often get reimbursed for the work that's happening. I mean, I'm not going to complain. I think this is the way to go. And yet it's hard to get that feedback back to payers. Let's put it that way. That conversation back and forth is not happening to improve it quickly enough, to iterate so that practices that are reluctant can be convinced that this is worth doing. So there's a lot more there.
Thank you.
Carolyn Nava, were you still interested in speaking? Please go ahead.
Thank you. I think my thoughts, my question falls somewhere in between Carmen and Dr. Reddy. And it is about this data piece, because when we talk about stratifying this data, my understanding is that this is the seed for something better, for something that will create that grassroots change that benefits all parties involved. And the complications that you mentioned, Dr. Reddy, are very real. If you can even get data real time, that's great. But the lag in data collection, the consistency for data collection when we are all working in fields where privacy and all of these things come in, and who can see it and who can't see it. Can you speak briefly on this collection piece? And maybe I missed a memo because I'm really new to this table, but speaking to that collection piece on how is that standardized? And how do we determine, as Dr. Reddy was speaking, what is required, what will it take for this data to get closer to real time so that it is actually useful, and the cost, again, long term, the burden of staffing up or the burden of putting more on administration where administration isn't necessarily covered. How do we get closer to that equity position, covering inequities, when we know, especially in rural areas, smaller practices, they're not going to be able to keep pace with this?
Sure. So I think there are a few ways, both in the standards, and we can think about how to improve or enhance these, that we address data collection. So one, we really, especially with related to demographic data collection, really emphasize the need to collaborate and to create standards. I think we know that there's generally an effort to move towards standardization of collecting demographic data, but there's a lot of work to be done. So we point to a few places of collaboration. So there has been collaboration across the state to improve demographic data collection across state health plan purchasers, and then also point to the CMS framework for health equity, and then also the United States core data for interoperability. So there are lots of places where we point to current standards and current efforts to collaborate and to better standardize data collection. And then in terms of data exchange, we point to the use of the data exchange framework, California's data exchange framework, and really having folks use that framework. And then also, just in general, improving data exchange potentially through health information exchanges or other ways to improve data exchange. But we know that there's a lot of work to be done, and some of this is pointing to other collaborative efforts or other efforts outside of these standards that could help, influence better standardization or better data collection. And then, of course, welcome feedback for how we could enhance or, add to this work to improve data collection and standardization.
Stacey Hernandez.
Thank you. I just want to support the alternative payment models. IHA, for 3 years running in the Atlas report, has shown that if a provider takes risk, that's higher quality and lower total cost of care. So I really support this. I would really encourage, and I think you have it in there, that the quality metrics would be the same across Cover California, DMHC, all the payers, because that's very helpful for us as providers when we're trying to really measure quality to have them consistently. See, we can't go after, 98 tennis balls in different directions. Also, if you could encourage the attribution methods that the health plans and insurance companies use are the same, because they're different today and it gets very confusing as to who's attributed to you. We have 70% of our revenue is capitated under HMO, both commercial and Medicare Advantage, which is great. We know who we have. We know what the rules are. Under PPO and Medicare fee-for-service, we were pioneering NextGen with those experiments, and we probably won't do those again. As well as the commercial ACOs are very problematic because nothing is delegated to the providers. So they ask you to be at risk, but you have no controls except for gaps in care. And so our rule of thumb is that I'm not going to take risk if I don't have control of the total cost of care of that patient population. So we can talk later. I know you have some slides in terms of how you measure the percentage by type, but that's really important. And then the last comment is for collecting the data. It's very difficult frontline providers to collect all the information that may be required on the demographics. So I think purchasers or government agencies where people actually, their insurance is dependent on it, have a better opportunity to collect that more accurate information than what they're telling us, because they don't always want to tell us information. Thank you.
Barry Arbuckle.
Well, to begin, I too want to commend your work, Margareta, and that of your team on advancing this adoption of APMs, because I'm a big believer that more rapid adoption and expansion of APMs will help us with our goal of actually bending the cost curve of healthcare here in California. I noticed the language in a number of places uses the words promote adoption. Are there any teeth or enforcement mechanism that OCA has, or is it just more kind of cheerleading to move forward with APMs or make it easier for folks to move toward APMs?
Yeah, we do not have any enforcement mechanisms for, requiring the adoption of these standards, but it really will be that transparency, cheerleading, getting alignment, getting hopefully stakeholder endorsement and, healthcare entities to endorse and therefore commit to using these standards. So that's really our goal at this point.
Okay. And second of my three quick comments, I want to echo Stacey's comments about what we would call the harmonization of the measures and metrics for both measuring quality, access, equity. In the early days of after the ACA, when ACOs began to come out, our organization was one of the early ones to participate in every type. And we found our biggest frustration was both the government, CMS, and the state and the private health plans were all using different measures for quality and access. And even where they were the same, like measuring depression, they would use different techniques to measure depression at different timeframes. And the frontline provider cannot keep up with that. So I applaud that. If that's under the administrative simplification, I think that's a very good thing. And then finally, on number 5 of your APM standards, you're talking about engaging a wide range of providers. I think that's wonderful. I understand that. My only concern, and this will be, I'm sure, something that is worked out over the course of time, APMs involve taking downside risk, or otherwise there's not much point to them. Downside risk in its various forms, and focusing on under-resourced providers feels like a bit of a contradiction there. The concern is, can an under-resourced provider take downside risk? I mean, I believe that was the driving reason why the DMHC began to work on their risk-based organization criteria. They've got to have a certain bit of financial stability. And we had a few failures in California in the last several years of groups that effectively had no balance sheet. And they took on risk, and risk went the wrong way. So as we're thinking about that, we just need to bear those folks in mind. I don't want to exclude them, but I also just don't want to have spectacular failures while we're trying to do the right thing.
Thank you. Yes, we definitely recognize it's a balance, and I think where we're thinking is that there should be a pathway for those types of providers to take on more risk over time, and that it should, as David mentioned, be actuarially sound and support those providers to take on more risk and be more accountable for quality, equity, cost of care. But there should be some kind of stepwise pathway for those types of providers.
Thank you.
I see Simona Reddy's hand.
I just wanted to echo Barry's comment. I mean, everything I didn't say was said, like, agree plus on all of it. Back to the other reason for APMs, one is bending the cost curve. And bending the cost curve, we've already bought into the idea that it involves supporting primary care at every level. So I want to throw out the maybe controversial idea that we don't want to lose one primary care clinician out there, not one, right? So if we push those who are on the edge of retirement, this is the only way to do it, and you've got your paper system. I guess I'm very much in favor of, like, how do we consider meeting everybody where they're at? And I know Margaret has talked about that, and that's a major focus of this committee. So thank you for considering that. And then to do that and to support all the metrics and work that's needed in practices that are new to this work, we also need to consider the outreach technical assistance, right? There is investment in the practices, in the primary care environment at all levels, integrated large systems and small. And then there is that's why it's so essential to align, because if you don't align, then you have all the chaos you're talking about and excess cost from all of that on both sides. So you have to have that commitment to getting, and the reason, again, that this has been working with Alidate, and the reason that's been successful is because you have on the ground support, to each practice at every level to work on those workflows, right? Without that, we personally have struggled with one pair with all of that energy. We can't figure out who to talk to around contracting. And I could show you a set of emails where nobody we talk to knows who to talk to for contracting, right? And this is around aligning some of this work. So this is why we can't leave behind. It's not just about taking all risk. It's about keeping primary care motivated to do this and to see that this work is sustainable. And, that's the voice that we all kind of want to bring to it.
Parker Duncan Diaz.
I think my comments might be somewhat similar, but so I don't want to belabor them. And again, so I'm a family doc as well, and I work in an FQHC, so I work in primarily underserved medicine. And while I think any doc I know would support the idea, we need to move from fee for service and get to a much more universal and simplified system. What we also know is universally true is that primary care is the best investment in all of healthcare. And what primary care docs, I can speak for every one of them I know, get frustrated by is we hear that on one hand, and yet when the discussion focuses around how are we going to increase that, there are always conditions to that increase in dollar because of this notion overall that we need to change the cost curve of healthcare. Part of it's not so much of just changing the dollar of healthcare, it's about where we're putting those dollars. So while some of it is a mentality of a zero-sum game, we know very clearly the answer is more money to primary care does much, much better investment than anything else in healthcare. And to reiterate the point, the more you burden primary care clinicians and primary care staff in order to essentially get a few more pennies on a dollar or check a box to say, I've checked this hypertension twice, is really kind of diming us. And the number one driver of not, as Dr. Reddy talked about, of not getting people interested in healthcare to come into primary care is this notion of burnout, this notion of moral injury, of kind of not respecting the work. So it's a statement about what we really need is to invest more in primary care. And that money, wherever it comes from, that can increase our total cost. That's fine. It's about using our dollars wisely and, yes, get to the goal of getting us out of fee for service. But I just want to tackle and put a voice to this notion that bending the cost curve is not what it's all about. It's about spending much more wisely.
Thank you. I see Carmen Consti's hand.
Yeah, I'm gonna thank Parker for that comment. I think, you know, one of the, I think a lot of you know that I don't believe that value-based payments are the answer. The answer is a single-payer healthcare system. But I think if we're having APM standards, it's really important that we capture this notion that Kieran and Parker were pointing out, which is that APMs can cause additional burdens to primary care clinics, to these small providers who don't actually have the funding to be able to actually manage the APM systems that are pushed on them. So I think that could be something that could be monitored here, which is, are the APMs actually reducing the ability of providers to provide care and increasing the administrative burdens on individual providers themselves? I think that's really important to identify because, you know, if we're moving pots of money from care to administration, that's problematic. That's not increasing primary care. That's you know, reducing costs, but then also reducing care.
Any other feedback before Margaretta continues? Anthony Wright?
Yeah, I just I mean I appreciate these goals, and they are goals rather than like enforceable regulations. We hope that and I hope that they have enough detail to be useful to the entities that are trying to align, to provide some guidance, and then the work is in the further conversations to align. On number two, I just wanted my only comment is that we have implement payment models that improve affordability, and affordability is always defined in different ways, right? And the examples below talk about affordability to the system, and that's really important. We do want to reduce harmful and low value care. We do want to have efficiency and cost sharing, but I also think that it's useful to have an example or two of affordability of consumers at the point of care, whether it is like, you know, I know there's examples, and sometimes it's in the world of benefit design, but it can also be in the world of the provider, where like having access to free preventive services then incentivizes patients to actually use those services, which then can have a beneficial impact both to their health and to the overall system. And so just you know, when, you know, in many ways, financial incentives to reduce utilization have been through the means of co-payments and things like that. And I think I don't think that's the spirit of which intended, and I think the more that we can dive into the fact that we're actually talking about affordability both broadly, but also how people experience it in a specific way, because I do think a lot of the problem is the issue of financial barriers to people, and I do think we've had some progress under the ACA with free preventive care and things like that, and we want to continue to do that with regard to but in the ACA definition, it's very narrow to a very set things of preventive and not to things like diabetic test strips or asthma inhalers or a broader range of things that I think most people would consider as preventative, and it would be an improvement if there was affordability attached to that as well. Thank you.
Thank you. Yeah, we can definitely look to enhance standard 2, and we've addressed that a bit in 2.4, but we can look to adjust and enhance that. Thank you. Okay, I think then we will move on to our draft APM adoption goals and definitions. I know we are a little bit behind schedule, so I'll try to move quickly to get to your questions and feedback. So on the next slide, here I wanted to outline again our approach to the alternative payment model adoption goals and definitions. And again, the purpose of these goals is to promote a shift from fee-for-service based payments to alternative payment models and better align financial incentives for equitable, high quality and cost-efficient care. And I think as we noted in our last meeting together that we will use the Healthcare Payment Learning and Action Network, or HCP LAN framework, to monitor our progress towards the adoption of alternative payment models. And again, here as well, while we do not have the authority to enforce these goals, we'll publicly report on progress and monitor progress towards the goal. And then in terms of definitions, here our goal is really to define what counts towards APM adoption goals and use a standard set of definitions for how we are defining APMs and how we're defining what counts towards the goals that we set. So in your, I think you also have in your handouts and on the next slide, it's just a refresher of the HCP LAN, the Healthcare Payment Learning and Action Network framework that can be used to monitor the adoption of APMs or to categorize alternative payment model adoption. And we've seen in our work that APM adoption goals and kind of the landscape analysis that we've done of other states and nationally, APM adoption goals typically focus on arrangements that increase clinical accountability for patients and financial accountability for care. And those are typically categorized in categories 3 and 4. And adoption is typically measured as the percent of spend kind of flowing through or under a contract for an alternative payment model arrangement, or the percent of members attributed to an alternative payment model arrangement contract, or providers contracted through an APM. So on the next slide, we used, in developing these goals, we used essentially a set of 4 strategic decisions to guide our development of the goals. And the first is which types of payment models count towards the APM adoption goals, so using that HCP LAN framework. And the next is whether these goals should vary by payer type or by product type, so should they differ by commercial, Medi-Cal, Medicare, or by HMO or PPO products, for example. And then there are questions about how the goals should be structured. So, should they be based on a percent of members or a percent of payments? And then what metrics should the goals be based on? So if we can move to the next slide. This is we just wanted to provide an example of Oregon, who has also developed alternative payment model goals. And we used this example and several other examples nationally of APM goals to inform our work as well. So Oregon, again, kind of considered those same 4 decisions in designing its APM goals. So they limit the type of payment models that count toward the goal. And then they do not vary those goals by payer type or product type. And the Oregon goals are based on a percent of total healthcare spending and are designed as a series of stair-step goals until 2025. And so On the next slide, now that we've walked through our approach and kind of the key questions that were informing our work, we'll review our draft recommendations against those 4 questions. So, and then also note that we recently proposed these goals to the investment and payment work group and are continuing to receive feedback on these goals from that work group as well. And those will be incorporated in future proposed goals along with your feedback today. So, turning to the first question, should all or only certain types of payment models count toward the APM adoption goal? And based on stakeholder feedback, we recommend that only certain types of payment models count towards the goals. And those are categories 3A, starting with shared savings, through category 4C, which is categorized as financially integrated systems. And those categories listed on the slide should count towards the adoption goal. And the list excludes what are called categories 3N and 4N in the HCP land framework, and those categories do not have a link to quality. So it may be shared savings or shared risk models without a link to quality performance. And then also based on stakeholder feedback, we determined to exclude land category 2C, which is pay for performance payments, from the list of categories that count towards APM adoption goals. Based on the belief that these payments don't really promote APM adoption, or do not do enough to promote APM adoption, and don't provide those upfront financial revenue for providers to transform care delivery. And then we also recommend that the focus on categories 3A and through 4C is really that payments should be linked to quality. So that means if the provider is eligible to receive a financial bonus, or is at risk for penalty based on performance on specific predefined quality goals. And that definition in the blue box provides more information. And then again, you have more information and definitions in your handout and the appendix.
I'm sorry, we do have a question. Do you want to finish up the slide and then?
Sure.
Okay.
One more point. The other point here is that we recommend for category 3A and for 3B that those APMs be required to meet a minimum threshold for shared savings or shared risk. And this is an attempt to ensure that those types of APM arrangements that are built on fee for service have a meaningful amount of payment tied to either upfront or ongoing shared savings or shared risk, and also be tied to quality. And again, those definitions are in the handout and the appendix. Yes, the question?
All right, Stacey Herontis.
Just a question in terms of that blue box. If you're taking capitation and many health plans are not paying quality bonuses anymore, especially if you're full risk. And I'm not sure what the trend will be in the future. So I would suggest that you consider if those providers perform at high quality within the state, then that's deemed as quality payment, because the health plans are wheeling back payment for quality, the pay for performance programs.
Thank you.
Yes, Karen Savage Sangwin.
Thank you, Margaret. I appreciate this. And just so that I understand the sort of implementation that you're looking for, because I think before you had mentioned sort of recommending a little bit of a phase-in approach because of some of the concerns. And so this is starting with potentially an adoption of a model that doesn't include downside risk, right? And so just on the implementation, are you thinking that these standards would change over time to move folks along these different models, or that there would be sort of a stated phase-in for what qualifies as adoption of the model over time, or just can you say a little bit more about that?
Sure. And in a few slides, you'll see our goals and those proposed over 10 years. So we are proposing goals over 10 years to increase adoption of these, categories 3A through 4C. But, again, welcome feedback on that proposed structure, and then also, would adjust the goals over time, especially, once we get get closer to that 10-year mark.
David Joyner, it's your hand.
Thank you. Just another comment building on what Stacy said about Medicare Advantage. So for Medicare Advantage, we have professional capitation and global capitation, which includes professional and facility cost arrangements, which is very common in California. There's no explicit bonus or deficit for quality, but the CMS star score drives the revenue to the health plan, which drives the revenue to the provider. So in the way you've written this, I don't think that would count, because it's not like an explicit bonus or explicit penalty. It's more like the total amount is dependent on the star score, which is a measure of quality. So you might want to just adjust this definition so you don't exclude the way that Medicare stars works.
Okay. Yes, I don't think that was our intent to exclude that. Thank you. Okay.
Sumana Reddy.
A concern as APMs work towards taking on more risk, that need to have infrastructure to be thinking about all sizes of organizations becomes more important, because today as we sit, there is a often erroneous impression that the only way for primary care to be a livable proposition for most clinicians is the complexity of a larger organization. I know that not to be the case, but we could inadvertently increase the push in that direction. We really have to think always about, are we balancing out the potential increased reimbursement at these higher level, scale models? Are we balancing that out by rewarding the smaller organizations for the stickiness of the relationship? You can hold them to an equivalent level of not sending people to emergency room and so forth. All of that can be the same. But you have to look at the scale of reimbursement and ensure that it's somewhere in the ballpark. If it's not, that then, really works against those independent or smaller organizations.
Thank you.
Susanna Usage.
To build on what Samana and Kieran mentioned, I was more curious, but maybe just a comment as well, about how 3A and 3B would potentially have specificity on the type of organization or the type of payment, meaning the shared savings would promote and maybe help the smaller organizations, and specifically primary care facilities or primary care within larger facilities, even promote them to pull more patients in, pull more members towards them, and excuse me, share in the upside of that. But then obviously there's a lot more risk when you're potentially having procedures in outpatient settings, having procedures that maybe aren't necessary and whatnot. So I think it may seem more appropriate in some instances to have some of these methodologies be specific to those different types. So curious if that's already been considered.
Thank you for that feedback. So I think in our definitions, we provide pretty detailed definitions about all of these types of models and kind of like subcategories under these types of models. And then, but we can go back and take a look in terms of how we're thinking about primary care in those definitions. And then also, again, wanted to emphasize both in the standards and here, there's also, opportunity for things like upfront financial payments or through primary care capitation or other upfront payments that would count towards the goals with a link to quality. So if we can move on to the next slide, here we get to the remaining set of recommendations in terms of answering questions 2 through 4 that I shared earlier. So Here, we are proposing that the goal follow a stair-step structure that eventually reaches an absolute target, and we'll review that in detail on the next slide. And the steps will vary to recognize differences in starting points within the California commercial market products. However, we are recommending an absolute improvement goal that does not vary by product type. And then kind of our final recommendation is that APM goals should be measured based on % of members, and this is informed by work group feedback and also data from the Integrated Healthcare Association that there was little to no difference between the % of members attributed to an APM and the % of total spending flowing through an alternative payment model arrangement. So to accomplish this set of work and to monitor % of members, we are proposing to collect payer data by provider group using that expanded framework that I mentioned, and that's in your appendix and handout, which would include member months attributed to each category. And then also in parallel, we would monitor the % of total healthcare spending in each category as another complementary measure, but the goal would be based on % of members. So if we could go to the next slide. So here we are proposing this kind of table and summary summarizes all of our recommendations related to the goals. So one is that the goals, again, are based on % of members attributed to those categories 3A through 4C. The goals are structured as a series of stair steps with all payers expected to reach 75% adoption by 2034. And that qualifying APM arrangement must have a link to quality or a connection to quality, and we'll work to further define that based on your feedback today. And then all qualifying HCP land category 3A and 3B arrangements must meet a minimum thresholds for shared savings and shared risk. So the table outlines our proposed structure of goals, and this 75% is really based on current APM adoption across different product types and different product lines in California. And to recognize differences in starting places, the initial goals for commercial PPO products are varied compared to HMO and other lines of business. So I will stop there and again, seek your feedback. Thank you.
I saw Stacy Hrontis' hand first. I see Suzanne, Sumana's, Parker's. Thank you.
Thank you. So if I understand this correctly, in 2026, we would have to have, as a provider organization, 55% of our commercial HMO members under an alternative payment model, right? And then 35% of our PPO attributed lives, and then Medicare Advantage that'd be assigned to a same thing. The commercial PPO is what gives me a little bit consternation because it's dependent on our payers. And a lot of the payers use the ACO narrow networks as a competitive advantage. Also, we may not participate in those because if there's downside risk, but nothing is delegated, we have no actions that could improve the performance because the health plans are doing the utilization management, the health plans are doing the case management, the population health services. So I would like a consideration to say if over all of your population in all these categories meets that overall threshold, so an aggregate percentage and not absolute by each payer class.
Thanks for that feedback. And just to clarify or reiterate that these goals are based on payer adoption of APMs, but will be used, the provider adoption of APMs will be used to measure downstream. Yeah, thank you.
Suzanne, usage next.
Thank you. I was still trying to wrap my brain around some of the rationale around members or revenue, only because, and maybe I'm thinking just narrowly on non-primary care provider situations where part of the idea would be to reduce members in the system or reduce revenue in the system. So I don't know if that could have in the long term a unintended effect, right? We're working towards a positive, but then it ends up becoming a negative. So I know I'm not explaining that well because I think I'm trying to work through it in my mind. Whereas the very simple, oversimplified one seems like the number of providers measured through the contracts within these payers, right? Because then it would help make it easier for the providers. And some in the room have stated that they really want to adopt and appreciate this model. But there are structures that Stacy mentioned and others mentioned about the payer structure, that makes it a little more challenging. So I think the provider part, if I want to say it more succinctly, the provider percentage seems to very simply get at the idea that you have this kind of like chicken or the egg, because people have been talking about these advanced payment models for like at least a decade, longer than that. And so if we can get the motivation behind that to be able to say in a contractual provision, if the payer is motivated to be able to say to the provider, this model will help advance us further, what would you propose? And then that conversation is triggered a little more. Then it doesn't become only about membership, because then the provider can say, especially if I'm looking at the hospitals in the room, you'd like less expenses to be able to have higher net revenue, if that makes sense. Just thinking from a business perspective, if you pay less for an unintended procedure, then you have higher revenue, but someone also is not getting an unintended procedure. So that was oversimplified thought of how provider percentage might make more sense, but not just forcing the providers to do it, but doing it vis-a-vis the payer mix.
Well, I'll say our decision for membership was really based on kind of a thought that this is increasing the percent of members gets us closer to kind of our population health management approaches, and having more members under an alternative payment model arrangement is what we actually are looking to increase in terms of getting towards our overall goal of improving population health and equity. But we can go back and reconsider that. And I will say, I think the other consideration we had is that tracking the number of providers attached to an APM arrangement is more challenging than members or dollars. So it just presents kind of an administrative burden question as well.
That makes sense. And obviously, I think a lot of people in the room agree that getting more people to primary care is the goal. So if that's the kind of tipping point, then that makes sense. So thank you.
Sumana Reddy.
There's probably people in the room who know a lot more about this than I do, but when, I was working with payers around the actual details of the metrics and payments, there are standardized goals that say that these are different for Medi-Cal versus Medicare versus commercial, right? So I didn't hear about that here, and I wonder what the rationale is to not include that, since, of course, we know that the SDOH piece, if we're looking to incorporate that, means that our dual beneficiaries, for example, it's a different population, and therefore the levels at which these metrics are set. I know that's a conversation that you're probably thinking about, but I didn't see it here, so just wanted to throw that out.
So is the question about dual enrollment, or about how kind of we came up with these goals?
I'm afraid it doesn't directly. It's not about the adoption goals so much as the when you set metrics for success. And there's another whole piece there around the ways in which payers ratchet down, right? You've saved costs for them, you've reached this goal, so then the goal gets here and here and here. That's another whole conversation around, if you want to do this to provide a better support so primary care can continue doing what it's doing, if that's really the overarching goal, then we have to be conscious of not ratcheting these metrics, up and up, or depending on the metric, but changing that constantly to get to tighten the cost side. And there's got to be something, I know that these are just recommendations, but there's got to be something that catches when payers are looking to put all of this increasingly on primary care. The work is hard, you all recognize that, which is why I appreciate so much having this voice. And if the work is, I am bought into, this is worth doing. This hard work, we want to do. I want to bring everybody into doing it. And yet everyone's got to recognize that it's hard on the rest of it as well. So we're doing this and we're doing everything else we're doing. And the and is what our patients see first. And then some populations, and therefore some, and it's to simplify the most around SDOH, perhaps are dual beneficiary, are, based on income levels, will have more need. So those metrics in reaching them might need to be different. And I just haven't seen that.
Okay. I think that that's a really helpful consideration for our standards. So I think we can go back and look at the standards and how we're thinking about metrics and, recognizing the challenges of primary care providers, and then also social determinants of health and dual beneficiaries. So appreciate that. And we can go back to the standards to make sure that that's emphasized.
Okay, in our queue, we have Parker, then David, then Ken. So Parker Duncan Diaz.
Two entirely separate comments, but one's just a case vignette that's going to illustrate what Dr. Reddy was just talking about. So it doesn't give you any answers or no concrete suggestions. And then I'm going to have a specific kind of question about what you guys are considering. So a vignette to that. Again, FQHC, and we have a really nice managed Medi-Cal Arts partnership. We really work well with them. They have quality measures for us. And as a case in point, I spent hours the past really few months, but really acutely the past couple of weeks, working with one of my dear patients to get her and the 17 directly involved family members to accept that this patient was aggressively trying to die and move to hospice. The irony of my story is that we got her to hospice on Thursday, and on Monday, I get my inbox message through my EMR that says, oh, notification to the EMR, please deactivate, patient is deceased. The very next message I get, or through my email, was my report of my overdue or missing A1C. This is the diabetes number we're required to check. And one of my patients listed on there that I'm delinquent on was this very patient who is now deceased. Now, once you are deceased, I think they do take you off the denominator, but kind of the irony is we're working with a patient who for months has been on, we know like the least important thing now is checking her A1C. She's dwindling, she's going to die. And this was just kind of a cruel case in point, in that I am losing my potential for quality points in my clinic because I didn't force her to go to the lab for another lab draw while I'm spending 17 hours that are entirely not reimbursed in order to help this patient's quality of life, or the few remaining days that she had. So that to me is a case in point of kind of the struggle to try and find this balance of what's happening in primary care and how do you support it. And then my totally changing subject, whatever my question, and perhaps I should have asked this at the beginning on the introduction, was as I was reading in particular your part, I was thinking about how your group and how the thinking maybe of this whole of OCA in fact is responding to the SB 770 that has passed, which could potentially really change the landscape of the next few years about California's direction towards overall how are we going to think about financing healthcare, and whether you've had a chance in your work group to bring that up, or whether that's going to be an entirely separate work group working on that.
We have not discussed that in our work group, in the investment and payment work group. I don't know if Vishal or others have wanted to chime in on SB 770. But we can definitely take that back.
We could take that back.
Okay.
I'm just appreciating the time. There's so much to talk about. We did have David Joyner and Ken Stewart with hands. I wonder if we could ask you to make these very brief, and I think we're going to try to wrap up and have to get to lunch so we can have our afternoon discussion, which is also hefty as well. Thank you.
I'll make it brief. For quality, strongly encourage you to think about attainment as well as improvement. Many plans only focus on improvement. If you're a high performer, you get in this catch-22 where you can't improve very much, and you get no credit therefore. Our second point is, how does the starting point in 2026 compare to today? Do you know?
We have some data based on, Medicare Advantage, especially, and commercial and HMO adoption in the commercial market from IHA. So I'll share some numbers and then we can of course follow up. But what we saw in the HMO is that about 99% of HMO commercial plans were paying in category 3 and 4. However, that's there's the unclear link to quality. So there's, that link to quality that we discussed. So that 99% could potentially be overinflated. And then alternatively, for PPOs, 16% of payers are paying in categories 3 and 4 for PPOs. So we are asking for PPOs to make quite an extensive increase, at least in the commercial market, in APM adoption with these goals.
Thank you.
Great, and Ken Stewart.
Yeah, quick question on the commercial PPO. I come from the Taft-Hartley ERISA paradigm, and what thoughts are there to work on promoting adoption with them because they run their own plans?
Mm-hmm. Yeah, our focus really here is on the fully insured market, and we have, notes related to this in the standards that, DMHC adoption, but that's not something we've specifically addressed.
All right. Okay. Margaretta, is there anything else you need to say? That wraps it up. Thank you so much for that presentation.
Thank you so much for all of your feedback. Thank you.
Thank you. Okay, we'll take public comment at this time before breaking for lunch, specifically on this item 4. And starting in the room, excuse me. All right, excuse me, we will take public comment now, starting with the individual at the podium.
Hello, my name is Kimberly Buss. I am a family physician and I wear many hats, but today I'm here as a graduate student in Master's in Science in Health Policy and Law at UCSF and UC Law San Francisco. And I just have 3 quick comments. I do appreciate very much the discussion about APMs and the goal to increase APMs. I just want to say on behalf of the policy class for which I am here today, we are really focusing in my class on how we can increase the use of interprofessional care teams and co-location of multiple services for patients. And I want to make sure that those are considered when creating goals for APMs, such as including mental health providers, pharmacist care, community health workers, and other sorts of interprofessional teams in APMs, and especially for small and medium-sized group practices, that's very difficult with the current payment models. Second thing, I would like you to consider really focusing on increasing and the intended consequence of increasing utilization for the components of healthcare that are evidence-based at improving outcomes. And sometimes we focus on total utilization as if we're trying to decrease that, but there is some utilization that should go up. We talk about that in terms of access to primary care, but there's a lot of utilization that needs to go up to improve the health outcomes of the populations we serve. And so that should be an intended component of APMs. And then thirdly, I really want to make sure, oh, and just another quick comment that sometimes those intended goals of increasing utilization, that utilization we know works well, are not captured in our quality metrics. Many of them are not captured in quality metrics, especially if we're limiting the number of quality metrics. And so just want to make sure that's considered. And then the final thing is that many APMs require a single year accounting of savings or improvement, but many of the things we do in care, especially around prevention, don't lead to savings that occur within that calendar year. And
It's
so
2 minutes.
it's very important that we consider that. Thank you so much. I really appreciate it.
Thank you. Looking virtually for any hands raised. Again, for our virtual attendees, raise your hand and we will unmute you to speak. Looking back to the room, please step to the podium if you'd like to make a comment. Noting for the record, we have about 10 participants in the room. Looking back virtually, we have roughly 60 participants virtually. Seeing no hands raised at this time, that concludes public comment on this agenda item. We will now break for lunch. It is 12:36. We will return at 1:20. All right, welcome back from lunch. I'll give everybody a moment to get settled. All right, I'm going to begin roll call. Joan Allen.
Present.
Barry Arbuckle,
Yes.
Eliza Ojoyan,
Present.
noting she was attending virtually, we will check on that. Stephanie Klein, Carmen Comsty,
Present.
Adam Daughtry,
Present.
Parker Duncan Diaz,
Good afternoon.
Hector Flores, Sarah Gavin,
Present.
Stacy Herates,
Present.
David Joyner,
Present.
Ivana Krasinovich,
Present.
Tam Ma. Noting they were attending virtually, we will check on that. Carolyn Nava. Mike O'Day.
Present.
Janice O'Malley.
Here.
Samantha Reddy.
Here.
Yolanda Richardson. Karen Savage Sangwan. Andrew C.
Present.
Sarah Strokin.
Present.
Ken Stewart.
Present.
Suzanne Usage.
Present.
Yvonne Wagner.
I'm here.
Again, a virtual attendee. We'll check. Renee Williams. Anthony Wright.
Good afternoon.
Abby Yant.
Present.
Thank you. Roll call concluded. We will move now to, excuse me, our total healthcare expenditures regulation update, going to Assistant Deputy Director CJ Howard.
Perhaps it doesn't make much sense to take a mask off as soon as I start speaking, but bear with me. Lots of things we do don't always add up. So my name is CJ Howard. I'm the Assistant Deputy Director of the Office of Healthcare Affordability over the Healthcare Spending Targets branch. Going to try to work through this next section pretty quickly so that we can spend more time on the spending target. At the top, before I get into the slides and the deck, so we posted the regulations in October. We had a hearing, a regulatory hearing or briefing in November where we heard from a few entities. We're expecting to close our public comment period on December 1st, so we have yet to receive written public comment, and that closes again tomorrow. A little context setting, so I just want to note too that these regs are very much geared towards getting us through the initial baseline report. I think that there's a high potential or even likelihood that we would be updating and revisiting these regs in subsequent years as our program grows, develops, and evolves. Also want to note that the regulations do not speak, obviously, to the totality of all the data sources that we will need to measure total healthcare expenditures. We're developing a presentation on that will be in future meetings. And so what these are, though, they are the regs that we need to collect data from the submitters that we're regulating. And yeah, so again, just kind of reiterating, there's a myriad of different data sources. We're also just making sure that we're taking our statutory charge seriously to use to the extent possible existing or other publicly available data sources that we can get from sister departments and other agencies within the state or the federal government. So with that, I will start moving us through the presentation. Maybe. Of course, great. So just a little bit of level setting. On the statute for implementing the regulations. So OCA is required to adopt emergency regulations to establish the requirements for payers and fully integrated delivery systems to submit data and other information necessary to measure total healthcare expenditures and per capita THCE. OCA will use this information again for our baseline healthcare spending report, which is due by June 1st of 2025. Annually thereafter, OCA will prepare a report concerning healthcare spending trends and underlying factors, along with policy recommendations to control costs and improve quality, performance, and equity of the healthcare system while maintaining access to care and high quality jobs and workforce stability. And OCA must publish its first annual report by June 1st of 2027 based on the analysis of THCE data for calendar years 24 and 25, with the first enforceable year being the report that would be issued in 2028 for the change in spending from 2025 to 2026. How well these things work before all of you are watching. So a quick overview of the regs and how they're structured. So they define terms that are used in the regulations. They outline the scope of the regulations. They specify who's a required submitter and how voluntary submitters may request to participate. In general, a payer or fully integrated delivery system with 40,000 or more beneficiaries or covered lives, as calculated by December 31st of each calendar year prior to the submission year, must submit THCE data if the entity meets any of the following criteria. It is a Medi-Cal managed care plan contracted with the Department of Healthcare Services to provide full scope benefits to Medi-Cal beneficiaries, enrolls or insures covered lives in a Medicare Advantage products under Medicare Part C, enrolls or insures covered lives in commercial products in California. Non-mandatory submitters may request approval from OCA to register to submit data. Additionally, they explain how submitters in plan-to-plan contracts should coordinate data submission with subcontracted plans. If a required submitter is the directly contracted plan in a plan-to-plan contract, the directly contracted plan must obtain any necessary data from the subcontracted plan and submit the data to the system or to OCA. They also establish deadlines for submitter registration and file submission. And they establish other requirements related to data file specifications, test files, data acceptance and correction, and variance requests. Also incorporated by reference in the proposed regs is the data submission guide and attribution addendum. The total healthcare expenditures data submission guide is intended for payers and fully integrated delivery systems or submitters to use when extracting and aggregating data for submission to OCA. Submitter interactions described in the guide will occur via the secure THCE data portal. And it provides technical specifications on file layouts, reporting schedules, and other instructions to ensure the submission of accurate data in a standardized format. It also specifies that submitters will not be required to submit data files for the Medi-Cal managed care market category until the September 1, 2025 annual submission deadline. So there's a 1-year filing exemption as we work through collecting that data through DHCS and evaluating existing data sources. The Office of Healthcare Affordability Attribution Addendum contains a list of provider organizations and unique identifiers to be used when attributing total medical expenditures. Also note that this addendum is definitely meant to be a work in progress. We acknowledge that it is not a complete and exhaustive list as of today. It's something that we are continuing to evolve and develop and expand upon. All right, so submitters will report TME using pipe delimited text files to the forthcoming data portal. There are 5 file types. There's the statewide total medical expense, the attributed total medical expense, regional total medical expense, pharmacy rebates, and then submission questions. And the submission questions are attestations and confirmations that the instructions in the guide were followed when preparing data for submission. going to resort to using the slide phrase instead of my handy remote control here. Submitters will report TME categorized by claims payments. So there's hospital inpatient, hospital outpatient, professional, long-term care, retail pharmacy, and other. There's other member level payments, so capitation and full risk payments, member responsibility amounts. There's non-claims payments. These are population health and practice and infrastructure payments, performance payments, payments with shared savings and recruitments, and other. Next. So in addition to the file layouts and specifications, the data submission guide provides instructions on reporting allowed amounts from claims, including member responsibility after a runout period of at least 180 days, including claims for all California residents regardless of the site of care when the payer is primary on the claim, attributing member level expenditures to organizations listed in the attribution addendum using an ordered methodology, including estimates for members when certain benefits are carved out and claims data are not available, calculating standard deviation as a per member per month value, and requesting data variances if data submission requirements cannot be met. So last slide is just a quick overview of our planned rulemaking process. So we've published the regulations. We had the workshop, as I've already alluded to. We have the November Advisory Committee where we're all here today. We have the board discussion in December where we'll be able to discuss in further detail some of the written comments and feedback that we've had, as well as engage further with the public. We plan to have a follow-up with the board again in January of 2024. And then we're aiming to submit to the Office of Administrative Law in late January, February for the rules to become effective in the spring of 2024. With that, I don't know if there are questions or if we want to engage in further discussions, Vishal, and before we move to public comment.
Yeah, Stacy, go ahead.
I might not be totally following you, but I'm trying to understand when it comes to attributing expenditures to members and therefore to provider organizations. I'm assuming you're thinking for the PPO of some kind of attribution methodology. Is it going to be like a standardized attribution methodology for all plans, or are you going to allow plans? I hope not, but I hope, are you going to allow plans to each use their own attribution methodology for that?
Yeah, David, we in the data submission guide, we have an order of operations for the data submitters to follow, the plans to follow. So the first one is capitated delegated arrangements, and then the second one is total cost of care ACO arrangements, and then the third one is payer developed attribution methods. We have received some questions about that third option because it does seem kind of it's based on what the payers do internally. So that option is in there. It's supposed to only be followed after you do the first two. This is going to be a learning opportunity for OCA to get that data and see how payers are developing that attribution in that third option, and see what the data looks like before we report anything out on providers. And it is just for baseline purposes. We are aware that payers, they do generally follow. There are some changes on the edges in terms of, but more or less it's kind of the plurality of services delivered, plurality of professional services delivered by a PCP or provider entity, and then kind of taking all the inpatient spending together. But that we do want to get feedback on that from this draft regulation on that approach, and then but do also want to remind this is for the baseline report, which is not enforceable, and it's just a way for OCA to learn about the types of attribution approaches out there.
So I'll just, my input as a provider organization, we have 5 different PPO ACO models with 5 different plans, and every single attribution model is slightly different. And we burn a lot of calories trying to understand how members get attributed to us in different ways. And it doesn't really bring any value. My strong suggestion would be that part of this work be to establish a standardized attribution approach, simplify things. And personally, I just use MSSP's approach, keep it simple. But while you say it's baseline, as a provider, I'm going to be looking at my reports and trying to interpret them and understand them. And having each PPO plan have their own attribution methodology would just make it that much harder for us to verify who's attributed to us, why it's different from one plan to another. My advice would be to simplify by having a standardized approach.
Okay. Yeah, we could definitely take that back because we, we do expect these regulations to be updated. They're not going to be static. So depending on a standardized approach could be on the table for us to look at in terms of maybe not for the baseline report, but for the annual report where the spending targets are in effect, we could take a look at that.
I suggest it's a bridge you'll have to cross.
Yeah.
And I would cross it at the beginning as opposed to once everyone complains and then you have to cross it.
Okay. Thank you.
Thank you. I concur with David. The different attribution models, there's many grids trying to keep track of what each payer does differently. But that's not my question. On page 51, you have, on the first statewide TME, you have commercial or Medicare Advantage. Where does Medicare fee-for-service land in this? In total healthcare expenditures? I thought it was all payers.
Yeah, Medicare fee-for-service, we're doing direct data collection from CMS.
Okay,
Yeah.
okay. And then under the cap and full risk, are those going to be adjusted for benefit plan factors? Because each cap rate's different based on the benefit plan, you know, how rich the copays are or how, you know, how the copays are high or, you know, you have to hit a deductible before you start receiving services at a certain amount. So the capitation rates vary by the member's cost sharing, basically. And so if you get a cap rate's not really a cap rate. You have to take into account the benefit plan factors. Otherwise, you'll look like you're either a great performer or not a great performer.
Yeah, I would call on our consultant, Michael Bailett, if you might have any insight on this issue.
You told me last time you would get benefit plan factors.
Well, remember,
Please step to the microphone.
remember what we're measuring here is change over time.
Right.
So this benefit plan factor is only an issue if there's a profound change in benefit plans from year to year.
Right, which you have employers shifting from one payer to another to a different benefit. It happens.
Yeah. Yeah, on an individual basis. The question, and I think one worth testing is there a profound difference in benefit plan design that's going to occur from year one to year two? Because we're measuring in 1 year increments.
Right.
Right?
Yeah.
Yeah.
So my suggestion is to take the plan factors into account. And then lastly, the patient portal messages that our providers are getting that's actually bearing them. There's no, you know, reconciliation of those in any form or fashion in terms of, I was reading through some of the material in terms of, yeah, it's trend, but there's also the healthcare costs, and you may be able to up or downsize trend based on the total cost of care. So the portal messages are bearing our physicians. People are texting them, you know, messaging them while they're getting in their car after their visit. So it's something that I think in the future we need to really take into consideration of how we're going to value those non-claim services. Thank you.
Thank you. Parker Duncan Diaz and then Barry Arbuckle.
Caveat, this is out of my territory. I'm not a healthcare spending person because I just go from room to room and see patients mostly. But my question's around, and I think I understand this is trying to just get the initial big picture. My question's around is there a plan now or in the future to segregate or distinguish this total healthcare spending in terms of amount or percentage of administrative costs? Because as we know, that's a huge area of fat in our multi-payer system. And if we were to look at that and tackle that, you could finance a whole lot more primary care by figuring out who the worst offenders are in the administrative world?
That's a good question. That's come up at the board level as well. The different degrees of administrative costs at each level on downstream. By statute, we're required to measure health plan administrative costs and profits, not at the provider level. But we do know this issue is bubbling up, and it may not be a first year activity of OCA, but it may be something we need to dive deeper into in the future.
Thank you. Barry Arbuckle, then Sue Monteretti, and then Joan Allen.
On the slide that talks about the total medical expenditure categories, there are the obvious ones: hospital, inpatient, hospital, outpatient, et cetera. I appreciate we need to have an other category. My concern is this other category is going to be so large and unwieldy. I mean, by example, you have hospital outpatient, but you don't have non-hospital licensed outpatient. By example, there are over 1,200 ambulatory surgery centers in the state of California, 1,700 imaging centers, 650 dialysis centers, and 7,000 physical therapy centers. And they're all going to be bundled in with a whole bunch of other stuff. So add to that, business is moving from inpatient to hospital outpatient to these community-based ambulatory centers. There's a significant price delta there. I think you'll want to be tracking that to see that movement. So again, I know you can't get too many categories, but those would be obvious ones, I think.
Thank you. Sue Monteretti.
Attribution and discussion of it ties back to another APM related point as well, which is the onus on the payer or the data gatherer to make sure that data is accurate. And given that over these 20 years, I've seen dramatic differences between payers and their ability to feed this back, all of it needs to have some sort of ability to, in a timely way, feedback corrections. And anytime we've taken the time to go through that, one payer is 20% inaccurate on even things like attribution because of data gathering problems. So I think we very much need to factor that in as we run these programs.
Thank you. Joan Allen.
Just two, first off, wanting to echo Barry's sentiment that some additional granularity on the outpatient would be really beneficial, and like the categories proposed, that sounds great. So whenever we can get from that crawl, walk, run, would really love to see those added. And then just trying to take a little bit of a step back and understanding that these regs are to get us the data that we're missing. That there's an entire portion of THCE that we can already get through other data sources. And then these regs are meant to fill in gaps. Can you speak to what gaps are remaining? What that we would sort of as lay people think of as healthcare spending and spending just broadly in the system won't be captured either by these regs or what you can get through other sources?
I'm not sure that I think Michelle and I might need to tag team on this one. I'm not sure that I can speak to.
Yeah, Joan, I think it'd be what this advisory committee has talked about before, the out-of-pocket, out-of-plan spending. These regs wouldn't capture that.
Yeah.
Like behavioral health visits that are paid by consumers with cash.
And as we think about THCE, I think it would be really helpful as you're putting together that report of what sources are we getting different data from, is to capture also what are the known unknowns? What do we know we're going to be missing with this? And whether it is spending by out-of-pocket spending, spending the uninsured, et cetera, just so that we can keep an eye on what we're missing.
Yeah, any report we do, we would contextualize it and say what data it does represent and what's missing, which would be the categories you said.
Yeah, Andrew. Oh.
Just How about self-funded plans? I can't remember whether or not we have a way of capturing, I mean, it's a chunk. It's a lot of dollars going through ERISA type plans.
Yeah, self-funded plans. There's language in the regulations that address this. Uh, by self-funded plans are included to the extent that federal law allows. So they're not exempt under the OCA statute, but we do expect to capture aggregate level spending for self-insured lines of business.
And I'm sorry, and you're relying on the carriers or the administrators to do that, or the employers? I'm just trying to understand the mechanism.
Similar to other states that have spending target programs, the carriers that are also third-party administrators for employer-sponsored insurance, they would submit the data.
Thank you. Sarah Sorokin?
Does OCA have any responsibility, or are they making any plans to try to measure the out-of-pocket costs for behavioral health care, given that that is a significant cost for consumers that should, by law, should be covered, but isn't being covered?
Yeah, based on the feedback of this group and kind of elevating this issue, we are looking into how we could estimate that. There are some variables in the medical expenditures panel survey on out-of-pocket, out-of-plan spending. It would be an estimate. It wouldn't be, actuals that in the same way that the plan data is going to be, but it could be something directionally about how much spending is occurring out of pocket. And that's a work in progress. And it would be kind of something we could report on outside of THCE. And this is kind of what we think is going on, based on like survey estimates.
Thank you. Ivana Krasinovich?
Thank you, Andrew, for asking that question. I've been sitting here thinking about who the payer is here and I was like, am I the only one? I don't want to say anything. So, and Ken, I might need your help here too, because I think there's this question of Taft-Hartley funds, because I think right now we're not even included in HPD, and I'm not sure that our carriers are sending over the data. And then I think even with Unite Here Health, we're in a particular situation because we really just rent the networks. We pay the claims ourselves. And in California, we actually pay through a Blue Card system because we use the Blue Cross Blue Shield of Illinois as our home plan. So I know at some point I was looking into HPD, we reached out to Blue Cross Blue Shield of Illinois and they didn't know what I was talking about, right? So I just wonder about, so that's, I guess, I have a separate question about Kaiser payments, but maybe I just stop there and see if we can get some clarity. And I know Ken, you can help me out here.
Yeah, on the HPD side, I know that we're looking to generate as much voluntary submission from the Taft-Hartley sector as possible. And we made arrangements through HCI to reach out to the health plans to see about canvassing their self-funded clients to get them to authorize inclusion of their data in their regular submissions. And I'm pretty sure that that process is underway. But each Taft-Hartley administrator or payer can also make arrangements to voluntarily submit their data directly to HCI.
I feel like we have not heard anything, so I'm wondering where I don't want to focus on us because maybe we're again kind of unique because we're we're a national fund and a lot of these funds are more California based, but
there had been prior exercises like Anthem canvassed everybody when they entered into a new agreement with Sutter, and each client was given the option to exclude them from the network or agree to abide by every letter of the contract. But they had the mechanism to say yay or nay, and I'm pretty sure that that's been explored on the HPD side.
I guess I would want to know if we're how many people have actually, how many funds have actually done that, because labor is a big part of the business here in California, right?
Yeah, so HPD, we will be issuing a report by the end of February, by March 1st,
with some information about the data that we've received thus far, and it will include a final analysis of how much of the self-insured data that we've gotten. So it is voluntary. It's different for claims versus aggregated. So right under the Gobet decision, the claims data we can't require on the self-insured plan. So we've done some outreach. We'll have a better sense shortly of how much self-insured data we've gotten. We will be doing more outreach. But yeah, even we've not had a comprehensive outreach for the claims data for HPD.
And then again, so the payers would also have to report their Kaiser data. And this is all just as one big number.
Well, the health plan, each health plan, including Kaiser Permanente, Blue Shield, Blue Cross, all the Medi-Cal plans, will each be reporting their own.
They're going to report their
data.
own number.
Correct.
And can you talk a little bit more? Is it just one number, total medical expenditure? Like how is it?
And then the breakdown that CJ showed us of some of the categories.
Yeah, and I think we have in prior decks a little more detail that I don't know that we could reference really quickly, but I think we could get you the prior slide deck sort of I think detailed further what each
right.
level
So
of detail.
It's
not a single number with each.
Because Kaiser I'm confused about because Kaiser is kind of in the middle column, but so are they just giving you one capitated number, or are they expected to break out hospital, inpatient, outpatient, and all those other categories?
Sorry, this button doesn't. Well, I don't know if you want to respond to it. I think we've been working with staff on this, and we participate in HPD and we give them the granularity that we can. So it's not one number. So there are breakouts.
And can you tell us a little bit about the granularity? I mean, it's a lot of people in Kaiser, so how much granularity is there?
So I think that
they are required to submit the per instructions in the data submission guide. So I know that the Permanente, the medical groups are capitated. So it's a little difficult for me to answer because they wouldn't fall into the claims payments bucket. I don't know, Andrew, unless what's your interpretation of?
So again, the short answer is yes. We will actually have, inpatient hospital, we will have the categories.
Yeah.
I mean, it's reported today in rate filings, right?
Okay.
So we actually do a lot of reporting that is on this health plan type view, and we actually report detailed data to the HPD. So I think, it's not one big number.
Okay. Yeah, I guess because look, with our data, Unite Here Health, and then I know a number of other Taft-Hartley funds, Teamsters, UFCW, other Unite Here funds in California actually pay money to a third-party, data warehouse to what I call translate the Kaiser episodic payments into something that looks like claims so that we can validate their renewals, right? So we spend money doing this already, right? And even with that, Kaiser always has a black box, right? They have their, what's it called, the ICT, or you've got some, your special sauce box, right? For having coordinated care. I'm sorry, it's been a few months since I looked at the renewal. And like some of that I feel like is legit, you're a coordinated comprehensive system. So, okay. But then it also feels like it's the box that we can never really explain. And so we're looking for any possible way to get that transparency. I mean, we've talked about it here before. I don't know a single Kaiser client that didn't get a double-digit increase this year, right? And in the past, we've always been able to validate. This year, it's like, I don't know, there's just an extra 10%, and like that's not like we should be getting a better sense of where the money's going. So that's why I wanted to understand this. So I'll stop there because I don't want to take up more time on this. But it's a big and important spend for us.
Joan Ellen?
Sticking with the same theme, on, I guess it's the previous slide, where it goes into the file types. We can go one slide previous. And it's the one with all the green. That one, yeah. So this includes expenditures attributed to organizations listed in the attribution addendum, broken out by market category, age, and sex, and then also broken out by region. Will Kaiser be breaking their data out at this granularity?
That's the expectation.
Great. And that'll be separated by Permanente and Southern California Permanente? Great.
If it's, we do ask them to do it by the physician organizations. So those are the two physician organizations.
Well, I didn't see Permanente in the attribution addendum.
That's a good catch.
That's yeah.
Yeah.
We could address that.
They're not an RBO, so yeah, adding the two Permanente groups to that would be helpful.
Yeah.
All right, Anthony.
I appreciate the questions. Kaiser was one of my set of questions. I do think that there is good data that is filed at DMAC, but I don't believe it's broken down by benefit category. So I think there's things that we can look at further. In terms of black boxes, I think more broadly, like I are interested in how these proposed regs look in trying to get to total cost of care, look at hospital systems, physician organizations, like, just like if we do hospital by hospital, I'm not sure that we get all of what is going on at a Sutter, at a Dignity, at a, whether it's our big systems or big physician organizations. And it might be that it's implied as these mesh with other things, but I don't know if it's explicit. So I would appreciate that. And then I know we answered a question about Medicare fee-for-service, but not necessarily Medi-Cal fee-for-service, and so would also just love if there was further explanation about the office's intent with regard to this.
Yeah, with as CJ mentioned, we're working with sibling departments on existing data, which is why there's a 1-year delay for Medi-Cal MCO reporting. We do still intend to collect that data. It's just we're going to work with DHCS on what data they have. Some of it may be in the MLR filings or rate development template. And then that's for MCOs, and then for fee-for-service Medi-Cal, we would get that data directly from DHCS.
And then more broadly on the question of hospital systems.
Yeah, and in terms of the hospital systems and physician organizations, that CJ and Vishal sort of explained the provider attribution. So there are the different stages of provider attribution. So like a big Sutter system or Dignity, we are attempting attribution. It's a lot easier, obviously, on the HMO side.
Yeah, and this the attribution addendum is not the full list. We're still building the list, and we'll continue to do so through the spring. That's kind of the TME approach based on attribution. But then, as we mentioned at other meetings, at the board and advisory committee meeting, we would still need to develop other measures for specialist physician organizations and hospitals. So we're still working on that, and we'll come back to this group with that in the next year, or the coming year.
Seeing no other hands raised at this time, I think that concludes this agenda item. We will now take public comment. If you'd like to make public comment, asking individuals in the room to step to the podium, and individuals online to please raise your hand. Seeing no one in the, go ahead.
Just make a couple of brief comments. Ben Johnson from California Hospital Association. Really just align ourselves with a few of the comments that were shared by advisory committee members. First on concerns really about lack of opportunity for providers, as well as sort of lack of understanding of how the office would really validate the accuracy of the data that is ultimately being submitted by providers, including the attribution of the expenditures to the provider organization. So would seek changes to allow for accuracy and appropriateness of the attributed expenditures to be incorporated. And then secondly, also concerned with the really lack of standardization in terms of the patient attribution methodology, especially in that step 3 portion. Even if the office does wish to do some sort of testing of different approaches and so forth at the outset, I think it makes sense to establish at the outset more requirements and limitations on the total amount of flexibility that payers have in this regard. So limiting, for example, to sort of primary care organizations or PCPs or similar providers who are providing similar type services, restrictions around changing methodologies sort of midway through a reporting cycle and so forth. So we'll have a few other technical comments in a letter coming, but thank you for allowing the opportunity.
Thank you. Looking online, noting we have roughly 50 attendees online, seeing no hands raised at this time, looking back into the room. If you'd like to make a comment, please step to the podium. Seeing no one at this time, noting we have about 8 estimated public attendees, that concludes public comment on this item. We will now move to the spending target discussion.
So I'll be covering a mini agenda for this portion. Next slide. So we'll be covering historical healthcare spending growth in California, and then talking about the different types of economic indicators and using historical versus forecasted growth, and then also population-based measures per the statute requires us to consider. And then time in terms of setting a multi-year target, talking about the duration, and then adjustment factors that could be applied to the spending target. This input that we're going to collect today will be conveyed to the board in December. I do want to note that we did also receive the presentation you're going to receive today. A similar presentation was given to the board in October. So we'll review periodically. We'll pause to give you feedback on what the board said at that meeting about specific topics, so we'll be ensuring that feedback loop between the board and advisory committee is occurring throughout this discussion. Next slide. So I do want to just remind the members about the statutory concepts. So there's references in this OCA statute to methodology and target setting. The enabling statute requires OCA to develop a methodology for approval by the board to set spending targets. And then the spending targets themselves also have certain requirements. And I do want to distinguish between 2 terms that we're going to use in this discussion. One is the target methodology, which is about the process and review of data to inform setting of a target, adjustment factors for future targets, several criteria and adjustment factors related to Medi-Cal, and then evaluation of adjustments related to quality performance, and then also the organized labor cost adjustment. So that's all part of the methodology. And then the target setting, when we reference that, that's actually the actual spending growth target percentage value. Next slide. So this slide, this table lists kind of the requirements for the methodology. I won't read every single one, but just we'll call out a few. So for the methodology, it needs to be available and transparent to the public. It needs to review historical trends and projections or forecasts of economic indicators and population-based measures. And then there's also consideration of potential factors to adjust future spending targets. This is a exhaustive list that we put here. It's just some representative examples of looking at employment cost index, labor costs, consumer price index, urban. There's a longer list in the statute for those adjustment factors. And then on the right-hand side is the target. So there's a set of requirements related to the target value. So it also needs to be developed with a methodology that's transparent and public and available to the public, promote a predictable and sustainable rate of change in per capita THCE, and then be set for each calendar year, but allow for consideration of multi-year targets, and then other factors such as promoting improved affordability while maintaining quality and equitable care. And then the next slide just goes into more details about other requirements for the methodology and the target. And then we added a column for sector targets, which the board can set targets by sector. So just as a refresher, sectors could include geographic regions, types of healthcare entities, and individual healthcare entities. So we won't focus so much on sector targets today, but that is something for the future. And then these other columns also describe other future discussion items that we have. So I know I started off on the right-hand side, but I'm going to go back to the first column. So the methodology will also, there's some provisions related to Medi-Cal. There's provisions related to organized labor cost adjustments. So we're not going to focus on that today, but that's an area for discussion in the future. And then the second column on the target does talk about the target needing to be developed, applied, and enforced. We're not going to talk about enforcement mechanisms today. And then, there's other requirements for promoting the stability of the healthcare workforce. Just putting a pin in those issues for now. So we can move on to the next slide. So I'll be going over some trends, and some of this data many of you will be familiar with. Just one more slide. So just bolded kind of what we're going to focus on in this portion of the agenda. We're going to review historical cost trends, and the statute requires us to do this. And then also we need to have differential treatment for COVID-19 years. Moving on to the next slide. So this is data from CMS, from the National Health Expenditure Accounts. They put this data out periodically. These are estimates from their actuaries. The total, the line in the blue is the total per capita number of 10,300 in 2020. So over a 20-year period, the average rate of change is about 5% annually. And then breaking out the different markets, there's different trends. Medicare grew annually by 4.1%, and that's the orange line on top. And then Medi-Cal spending grew by 4.6%, which is the gray line. And then commercial or private insurance is shown in yellow, which grew by 5.1%. And then
You have a question, Sarah Sorkin?
This data, does it break out into more categories like Medicare Advantage plans versus traditional Medicare, and the change in spending growth between comparing those two? And same with Medi-Cal, like managed care Medi-Cal versus
Yeah.
MCO or
The
fee for service?
The CMS data doesn't break out Medicaid that way, but or at least this chart doesn't. But um, that probably is available somewhere from CMS, and fee for service, Medicare Advantage, and then with Medi-Cal, there's data that DHCS reports to CMS as well that provides more granular breakouts than this. This is pretty aggregated.
Is there a way we can get that data, or maybe you could just point us to where?
Yeah, we could circle back on that I'll flag that for staff to follow up on. And then just moving on to the next slide. So these are just different breakouts based on different time horizons. You could kind of slice it different ways to see how much the trends change. The smallest look back period of the last 5 years is about 5.2% average change. If we go back over a 20-year period, it's about 5.4%. These are California specific numbers. And then going on to the next slide. So OCA has a staff recommendation, which we presented to the board in October related to historical cost trends. So to promote improved affordability, OCA recommends that the annual per capita healthcare spending target percentage should be below the long-term trend of 5%. So this is, in order for a spending target for us to kind of deviate from the trend, we should at minimum, we should set a spending target below 5%. So as many of you are aware, there are some anomalies associated with COVID on healthcare spending. We didn't look at calendar years 2020 and 2021. That CMS data only ran through 2020. So we don't yet have state level numbers for 2021 and beyond. So we may revisit any impacts on spending associated with COVID. But just as a flag that we're not making any recommendations based on that, because the statute does give us guidance on that due to the, people delaying care during that time and spending going down. So just want to pause here for any questions from the advisory committee on this staff recommendation.
So we've got Abby on, then we'll go to Adam Daughtery and Anthony. Okay, thank you.
Yeah, I just wanted to ask that we update these trend figures because last year, and we're looking and forecasting for next year of being at least 7% year over year increase in commercial. So this presentation would have sat well a year ago, but it doesn't now, and we don't know if we're in the middle of something, at the beginning, at the end, but we're definitely at a price point right now that's going up much higher than it has in the recent past.
Thank you, Adam, and then.
I was going to make a similar point, but also to note that in the chart and graph under the fine print, it excludes health insurance administrative expense and profit and the net cost of health insurance. Correct me if I'm wrong, but we will be including those in our target, correct? And if so, does that 5%, if we're trying to compare apples to apples here, which way does that affect that number if we are indeed including the actual cost of health insurance administration and profit?
We'll be able to look at it both ways, with and without health plan admin costs and profits. So for total what we're calling total medical expense, which is those first three buckets of claims, non-claims, and consider out-of-pocket spending. So at the provider level, we wouldn't bake in admin costs and profits because that's part of the health plan. But then at the statewide level, we would be able to kind of put that back in. But are you, just to make sure I understand your question, are you, I wasn't exactly following your question. Is it about the,
Just for the
it's not apples to
perspective
apples?
of this of
Yeah,
you
okay.
and the committee, it seems like that 5% would be a little conservative, kind of going back to the first point.
Okay.
Thank you. David Joyner.
Yeah, a couple of comments. First of all, another build on Abby and Adam's point is, I think it's dangerous to just look historically and say that's what it should be in the future, because I think you've got to adjust for things that you know are happening. So I'll give you two examples. One is the state passed this minimum wage bill that we know is going to increase labor costs in healthcare facilities by government action. And when we know things like that are happening, I think we should be adjusting the trend target based on that insight. Another example is, healthcare innovation. Ozempic, for example, is going to drive up drug costs. Maybe in the long run, it might actually reduce total healthcare expenditure. Who knows? But I think we should. I'm uncomfortable with blindly applying historical numbers without looking and understanding what factors are driving healthcare costs in the future and adjusting for those things. The second point I wanted to make is that when you think of it per capita, you think about Medicare, Medi-Cal, and commercial. In reality, Medicare and Medi-Cal per capita spending is really set by the government. It's not really set by the providers or even the health plans. It's set by whatever the government decides to reimburse. Commercial is more of the market, the tug of war between health plans, employers, and providers. But for Medicare and Medi-Cal, it's just different. It's largely driven by what the government decides to reimburse. And so I feel like this is going down the road of applying a standard number to all three of these. Whereas the reality is that the number that should be applied is also a reflection of whatever the government has decided to do with Medicare and Medi-Cal reimbursement.
Thank you. Stacey Hrontos and then Andrew C.
Just to add on to everybody else, I'm looking at the cost inflation that we've had with staffing, being unable to hire physicians because they're either retiring early or leaving the state of California. Same thing with staffing. And I worry about something below 5% when our costs are increasing at a much greater percentage. Staffing expenses, 26%. Supplies, 47% compared to year. It's just pretty phenomenal, what we're facing. And then the unfunded mandates, such as minimum wage and compression for our staffing, construction, everything else is just kind of out of our control with the expenditure. So setting a one target without taking into account some of these market dynamics seems a little bit dangerous. I worry that we won't have the providers in California to take care of our patients.
Yeah, I guess it's kind of variations of the same theme, right? So we're exiting maybe pre-pandemic, like a 10-year period where it's remarkably stable, right? In terms of costs, we're just like, yeah, it's, 5-ish%. We're pivoting, right? The interest rates are way higher than what they were before. Inflation's a bit higher. I guess this occupational hazard, I'm an actuary, right? I want to start with my core trend, which is, build up, your input costs, right? You start with labor, look at pharmacy, you look at kind of the demographics, right? I mean, every year things will change. You look at the technology, you kind of build up a trend, and then, we certainly want to lower that, right? To actually have, to lower that trend, but you kind of have to do it pretty responsibly. You just can't take out a lot all at once. And, healthcare is a service industry, right? At the end of the day, it's people. And so we don't want to create perverse incentives that end up being cost cutting, or it's just, we have to take costs out of the system. I think everybody's there, but we have to actually kind of work through it methodically. And I think I love the presentation, the way it's laid out, because I think you're trying to get there, right? Here's one factor, here's the next factor, and then there are more factors next time around. But I guess we kind of just want to get in the we kind of have to, we're not in the same old. So we have to actually think about, how are we building up the target and what incentives are we creating? And how do you account for things like, breakthrough innovation, right? I mean, I guess GLP-1s, I don't know if I'm going to put that in that bucket, but, Sovaldi not so long ago just really hammered everybody in terms of the cost, but it was a cure. What were we going to do about it? So anyway, I'm sorry.
Anthony Wright, and then Ivana Krasinovich, and then Sarah Strokin, and then John Allen.
Yeah, I mean, I think I understand the notion of this question. I think later on we're going to talk about like the actual like methodology of settling on an actual percentage based on is it median growth or something like that. And I think that's the way that we'll actually come to a number. But I do want to suggest that people are struggling with affordability and have been for many years. We know that this country and the state and this country, we have historically much higher healthcare spending than in other places in the world, and that and if this was an exercise, if this, I really want to caution us not to be in the exercise that the point of building a number is to just take a question of addition, where we just add up our labor costs, our technology costs, our drug costs, and whatever, and then that's the number, and then that's what we should be we should accept, whether or not that's affordable to actual people. Like the part of the point of this is to try to create some incentives for innovation, for trying to, that may not exist in the marketplace right now, to get to something that is affordable, a cost growth that is affordable for people as they live their lives, and to arrest, like to bend that cost growth curve that we've seen go up at an unsustainable way. So I would I think it's useful to have like in the back of our head that like 5% is historically where we've been at, and so we're looking to try to do better than that. And yes, that will take some innovation. That will take some innovation in both how we deliver care, how we pay for care, how we in broader investments and changes in it may be society. But I think if we set a goal that is just what we've done before, I think it's useful for the staff to have said, let's set a goal that is not just what existed for the last 5, 10, 15, 20 years, or then what are we doing here? Like, and so I just want to just be clear about that and what I think folks are doing. And I think but I don't want to discount the question if there are real things like a high-priced drug like a Sovaldi, like other things like that. And I think that's why we're going along with this approach rather than a more strict rate regulation approach. If we're just going to do this, we're just going to do that. We do have mechanisms in place to say, okay, well, maybe this year with this this new blockbuster drug or technology has come on, we'll make an accommodation. We'll make an accommodation by that. But I think that's different than sort of just saying, okay, let's just expect that everything that costs today is going to be borne by the consumer, and we're not going to ask the industry for any innovation or any like a way to like figure out a better way to get an affordable product to consumers. So I just want to just say that as well. Thank you.
Thank you. So Ivana, Sarah, Joan, and then Carmen.
Well, Anthony made it easy. He said a lot of stuff I would have said, so I want to give a big ditto to that. I do think like the affordability is in the title of this body of what we're supposed to be doing, right? I can't help myself but give another example from Monterey. This year workers will not get any wage increases because we're running such a big deficit in that plan, and the only reason that plan hasn't gone under is it's being subsidized by workers in other parts of the country, right? We looked at our claims for 2022. We all know the RAND study came out and said Monterey hospitals are 400, 500% of Medicare. We looked at our inpatient claims for 2022. We paid on average 559% of Medicare, and we were like 95% in CHOMP, right? So it is 559%, right? I mean, the deficit of the plan is completely driven by the hospital prices. If those hospital prices were more in line with the state averages, workers would have gotten a raise. And Monterey is one of the most expensive places to live in the states, right? These are immigrants and the working poor who got no raise this year with the inflation that's going on because CHOMP is charging on average 559% of Medicare. So like, I understand, like we pay for Sovaldi, and you know what? We all freaked out about Sovaldi, and guess what? We all survived. Now we're freaking out about Ozempic, and like there are those things, and that's why we're talking about rates that are higher than the rate of inflation and have been for a long time, right? So I think we have to be, we have to have an aggressive, bold goal, because otherwise we won't get the innovation and we won't get the changes that Anthony, so eloquently articulated.
Thank you, Sarah, Joan, and Carmen.
Before you go to that, I just wanted to circle back to Adam's question. So the dollar amount would be higher if we were to, put back in admin costs, but the percentage change wouldn't really shift from that 5%.
We've been talking about, or some people have brought up things that increase spending, but at least in my view, there's a lot that is inefficient in our healthcare system, in my experience, that should also be given equal weight, and how that could make healthcare more affordable. Like, I probably haven't been at a workplace as a mental health therapist where there isn't an overabundance of middle management really helping with the gatekeeping process with patients and clients. And I tend to think, well, if there was less resources dedicated to that and more resources dedicated to us therapists or mental health workers who actually provide the care and who are paid less than these middle managers. I'm not saying this is like the only way to improve healthcare costs, but just little things like that I see and I don't hear really being talked about as ways of balancing out any increases in spending. And even I'm like thinking this is an anecdote, but just recently I pulled my hamstring and I didn't know that it was a hamstring pull. It was at the back of my knee. I could not get an in-person appointment with a doctor for a week after I was pushing for an in-person appointment. And I ended up going to the emergency room because I didn't know what was happening. It was affecting my walking. And it ended up being a mild hamstring tear that really should not have been looked at an emergency room. And like, if these are the things that are happening to a lot of people, no wonder our healthcare costs are as high as they are.
Thank you. Joan Allen?
As we're setting any target, it's really a pretty fundamental decision as to whether to set a target that is a low bar that pretty much anybody can step over unless they're really not paying attention, or do you set a bar that folks have to work a little bit to step over? And looking at the progressive enforcement in the statute, it's very clear that the legislature was looking for a bar that not everyone would clear, that we are really looking to bend the cost curve. We are looking to actually make healthcare more affordable for businesses purchasing healthcare and consumers paying for it. And that is why the enforcement structure has so much in it that is about performance improvement, providing technical assistance, working with entities to understand why they missed their target. Is it a Sovaldi issue? Okay, great. We can isolate the Sovaldi costs. But that shouldn't get baked into the overall target. That is why we're building up such a robust enforcement system and why we are investing a lot in helping entities really meet these targets, is because there's the expectation that this should be hard, or at least it shouldn't be a bar that's so low that we can just step over it.
Thank you. Carmen Comsey and then Simona Reddy.
Yeah, I really appreciate, Joan's comments, Sarah's comments, Anthony, even, I think, really fundamentally what we're talking about here is that, we have the importance of the data collection side and the spending target side are really important because we need to know when, when going above the target is unwarranted. And that is the key component here. This is why getting administrative costs and profits are important because that is not going to care. And I think that is why we need to set these targets at, as Joan said, a high bar so that we can figure out where the spending is not actually going to providing high quality care to patients when it's being taken out of patients' pockets. And I think that's why we had to be aggressive with the targets that are being spent, and we had to be aggressive with the data that's being collected and doing that analysis of where is the money going. And to be frank, complaining about healthcare worker wages is anathema to our goals of high quality care because those are the workers who provide the care to patients who can, if we're cutting wages or labor costs, that will reduce the quality of care, plain and simple. And I think we need to recognize that. And this is really important that, there isn't this idea that if healthcare worker wages or costs goes up, that means everything else that is being spent on, whether it's administration or profit, also has to go up. You know what? That should come out of profits. If we need to have a resilient, healthy workforce, take that out of profit, and we can meet our spending targets.
Thank you. Simona Reddy.
Sarah's comments were wonderful and really appreciated because that's my paean to simplicity, right? That when you have a flat organization, I can tell you, I was just going to give you a numbers observation that my biggest private payer, I have no ability to negotiate, and we're lucky if we've had a 2% raise in reimbursements year over year. Some years, none. So you can imagine we're quite far behind there. I even got a letter from them the other day that I had an inordinate number of, from Florida, I might add, an inordinate number of physicals plus visit codes because, now I'm piling on as much as I can in that one visit for the patient. And I often tend to write off that care because I know that then is going to go to the patient's deductible. They have to go back, pay a copay. We would have shut our doors a long time ago if I did that 100%. But let's say I do it maybe 20, 25%. That's still care I'm providing that the insurance company is benefiting from, right? So maybe 2%. This particular payer last year I switched to for our own plan, and I'll go home and read my booklet and talk to the broker tomorrow, but the best premiums I can find for a pretty healthy population, the increase is 12% for me, right? So the math doesn't add up in any way, and yet I've been so influenced by the $25 thing and my fear of losing my well-trained staff to the hospital clinic that's now in the APM game that I have reached that now for most of my staff, right? So I don't know where the math is going to go. Still an experiment in progress, but our biggest goal is to keep our patients out of the emergency room and be accessible. So to do that, and we're still achieving that, okay, you call, we're a small organization, we'll do our best to work you in same day, right? And we can do that. We are doing that better than a Kaiser or better than any other organization. That's what I'm bending my brain to all the time. But you can't provide a stick on that. Oh, we're going to report card you because of your access. You know how they call and like, what's your next available and your next available? No, we're trying as hard as we can already. So again, back to if you don't resources enough to be able to bring in the new clinicians to be able to keep doing that kind of thing with that tight a model that knows exactly how it needs to perform, then the system starts to crumble because I'm willing to spend 45 minutes to tell somebody why their 23andMe report may not mean that I have to do all these things for them, right? I mean, we're trying to understand when I brought up molecular, I mean, that's the work that I'm trying to stay ahead of to keep costs reasonable for people. And we're not even thinking about how to counsel and do those things. That's just my independent work, right?
Thank you. David Joyner.
I just want to make a counterpoint to this argument about the we should set aggressive targets. So I think personally, I think there's from the affordability standpoint, it's very appropriate for us to try to set aggressive targets. But at the same time, we can't engage in wishful thinking. And so, for example, in Hill Physicians Medical Group, the labor costs are probably 70% of the cost of delivering care. And so it's literally impossible to say, we want you to meet an aggressive cost of healthcare goal. At the same time, we want you to substantially invest in your wages for nurses and practice managers and APs and MAs and so on. They are connected. And so the plea I'm making, and the same argument could be made around technology, is that we should set intelligent targets that are reflective of the reality, and we can't engage in wishful thinking and decide we want to push something down here, but we're going to ignore the fact that that it will inevitably will have an impact on other costs.
Thank you. All right, seeing no additional questions at this time, we will continue our presentation.
Yeah, we're ready to turn it over to Assistant Deputy Director CJ Howard to discuss economic indicators and population-based indicators.
All right, I'm back. I'm still CJ Howard. Good to see all of you again. Let's talk about some economic indicators. Maybe if I just... We're going to make an adjustment here on the fly, see if this works, so that I can move slides around. All right, so to anchor our conversation into the statute, and again, the way we tried to lay this out was we know that all of this will have to come together in the gestalt of the system in terms of how we set a target, but for analytics' sake, we can't talk about all of it all at once. And that's why we're trying to break this up a little bit so we can go sort of piecemeal through this. And then obviously we'll have to revisit all of these elements once we kind of go through them at least once, if not hundreds of times. So we're going to dive into the concepts here where we need to, the methodology needs to be based on a review of historical trends and projections or forecasts of economic and population-based indicators. And similarly, the target needs to be based on a target percentage with consideration of economic indicators and or population-based measures, which we're actually going to, that's another section where we're going to talk about the population-based measures separately. I thought I was so slick by moving the podium. That wasn't it. All right. So first of all, we had discussion with the board about the use of historical and or forecasted data. So just to kind of level set a little bit about the historical data. So why, sort of pros and cons, why use historical data. So the historical data reflects to varying degrees volatility in year-over-year changes. It can include booms and busts, pandemics, times that are healthier fiscal times. So there's a lot of noise in the historical data that we see. Historical figures are relatively easy mathematical calculations. So they're easy. One, the historical data is easy to get. It's pretty objective. It's verifiable. And unexpected events that we might see can be addressed through smoothing or weighting or extending the look back period if we were going to use historical figures in the methodology to set the target. Forecasted data are predictable and they're stable. You know, usually you'll see the wavy line of the historical data, and then when you see the projection, it was somebody's smooth line where they used some methodology to forecast what the future was going to look like. Forecasts, as we know, generally don't always play out exactly as forecasted. I'm sure if I were to draw a line through the stock market, I would be a very rich man. They don't always play out as they might be forecasted. Also, the projections that we have most readily available to us don't always look out very far into the future. Generally, they're limited to a few years, so we might need to rely on other entities or forecasters. And so those forecasts are subject to the philosophy or the outlook of the person conducting the forecast. So just kind of level set a little bit in that differences between historical and forecasted data. So as we look at these economic indicators, I think that we had this discussion back in September about some of the indicators that we might consider, and also went back to the board and discussed those as well. And so we looked at gross state product, potential gross state product, median hourly wage, and median household income. The figures of what they would be, the historical averages are presented here, as well as some forecasted figures about what they might look like going into the future. I think it was in this body back in September, there was discussion kind of around focusing more towards measures of consumer affordability. For example, the median hourly wage, median household income. I'd say the board seemed to very much be going in that direction. They seem to sort of voice favor towards those measures of consumer affordability over sort of macroeconomic trends or measures or metrics. So just for us to review the changes in the data over the past. So the annual growth rate in gross state product, the per capita grew by approximately 3.9%, but you can see there's some relatively high highs and some relatively low lows in terms of what the volatility in that looks like. And so we could think about using smoothing if we were to use this to inform a target. The annual growth rate in median hourly wages. So the overall median wages grew by approximately 2.8% annually. Again, you can see a few dips. You can see where there were declines, but the smoothed average is 2.8%. And then from 2002 to 2021, the overall median household income grew by approximately 2.8%. Marco, if you can. So the staff's recommendation that we relayed to the board was to promote transparency and public accessibility. The basis for establishing a statewide spending target should be a single economic indicator. The methodology to establish a statewide spending target should rely heavily on a single indicator of consumer affordability, specifically median household income, because it captures retirees and others not in the labor market. In several states have used blended approaches, the average change in median wage. And so because we said a single approach as opposed to blending them where we would weight, let's say, median wage with median family income or median wage with gross state product changes, where they've weighted these and averaged them. If you were to just use a single metric, you can get roughly to the same percentage change that other states have adopted as their spending target. And so we just thought for simplicity in communicating the basis for the initial statewide target, we recommended a single economic indicator. And we recommended using the historical data. Again, we think that they're easier to arrive at, they're easier for us to gather, and they're less subject to the whims of a third-party entity and how they may want to forecast the future. Again, I think I kind of already touched on some of this, but the board members, I think, generally were receptive to the idea of a measure of consumer affordability. Granted, some of them were suggestive of, or at least alluding to, discussing adjustments from there. So with that, turn it over for comments and questions.
Andrew?
I guess it's the mutual fund disclaimer, past performance is no indication of the future, particularly, I mean, right now, I mean, again, we're exiting a period after the Great Recession where, the Fed lowered interest rates, remarkably stable. We're at a point where inflation is pretty high. So I get it's easier to look at the history, but, just the economy right now, and we're trying to set a target for a future date, right? So we have to actually look at our best guess of what the future is. And we're not living in a zero interest rate environment right now. So I guess to me, it's we have to look at what we think it is. And I guess it's do you all really think it's going to be 2.8%? I mean, that really is the baseline question. I think a lot of us here are looking like, no, it's going to be more than that because inflation is more than that. So I guess that's kind of my thoughts on this.
Thank you.
I would just like to echo what Andrew said as well. And I understand the recommendation to tie it to income, but there has to be some connection to our healthcare reality of what the cost expenses are. I know the minimum wage is something that's real. We will be implementing over 3 years, and there's compression in that as well. So I think those factors need to be considered. RSV, I heard an advertisement on the way from the airport. I don't know if any of you know the vaccine cost alone is $250 to $525, just the vaccine, not storage, not administration. So those are new costs that we're not getting compensated for on a capitated basis. So my view is, 70% of my revenue is capitated. So anything new that's out there is new expense. Thank you.
Even
Feel like we're gonna have this existential back and forth. The other reality is that people can't pay if it keeps going up, right? Again, those Monterey workers got no increase this year, and yet they're supposed to pay. So I definitely, I mean, as there's been a lot of discussion. I agree that it should be the household income. So I'm glad that we didn't do some blended thing. And I mean, you have to base it on something, and a 10-year average is what we have. And there's going to be years where things are going better, and people are going to benefit from that. But I'm fine with this approach, so I would agree.
David Ryder.
I'm just going to continue the table tennis here. For me, it doesn't make any sense because if you think about it, like how much sense would it make to say we're going to price iPhones based on what the median household income, we're going to price rent based on median household income, or any of these other factors. The reality is in our economy, some things get more expensive, some things get less expensive, depending on supply, demand, technology, all these other factors. And so I think we should have a more precise way of looking at what healthcare costs should be, rather than just using a single number that is an outcome of everything in our economy. Now, not to say I totally hear that there's a healthcare affordability crisis, but I'm worried about the unintended consequence of setting a goal that doesn't reflect things like new technology and other things like that. And therefore, we get unintended consequences from applying a goal that doesn't match what's going on in the healthcare system.
Even.
I'm sorry, I don't have any patience for the healthcare in the same bucket as iPhones. I think that the reason we're here is that we consider healthcare to be a public good, and maybe we should be talking about regulating healthcare like a public utility. That might be a better way to go if we're gonna go down that route. So I felt like I had to say something on that level. I mean, look, the other thing is that we all know there's a lot of waste in healthcare. And I talk to kitchen workers all the time and say, what would happen in your kitchen to your chef if they had 30% waste in the system? And they were like, no restaurant would survive, right? So I think there is margin in this industry. And for years, it's been run on fee for service for the most part, where you get reimbursed. It's not even listen to the language, it's not even a real price. It's like, you tell us what, we're going to set the price, and then we as payers just have to accept it. And like, well, this is going to be a regime change. I'm sorry, but that's the only way we're going to sustain the system. Otherwise, we're going to have an increasingly small percentage of people who can buy healthcare, and everybody else is going to be, in Medi-Cal and Medicare and fully regulated.
Sarah Sorokin, Simona Reddy, and then David Joyner.
Yeah, I just wanted to reemphasize the fact that there, in addition to, increases in cost, there's so much waste and things that could help lower cost. In my years as a crisis therapist at Kaiser, about 6 years, it was a common thing for me to see people calling in crisis needing higher levels of care because they weren't getting the care they needed. They were waiting too long between appointments. And that's an area where, in my mind, I'm thinking if they were given the care at a lower level of care, lower costs that they needed, they wouldn't need this higher level of care that costs more money. And even in my current position, seeing people who are waiting for care and are some of our most vulnerable people who are even homeless. And again, it's the same pattern where they will access emergency services more. And just that we should really pay attention to the waste or the inefficiencies just as much as any increase in costs like a new medication.
Thank you, Simona, and then David Joyner.
I think I always find it instructive to look at systems quality and costs internationally and then regionally, and there's just so much to learn. And the reason that we're doing this work in California is because we care about that transparency will help us. And going back to some of these issues around how did we get to the point of not just a lot of additional administrative and those sorts of things, but all the crazy stories you all see around the bills people get and the navigation of them. I was going to go approach Evan on behalf of a patient of mine that I'm trying to figure out, just a really nitty gritty detail around, have you worked to negotiate this kind of thing down because it doesn't make sense. So, so much of it too that I see is that payers have not been very active in allying with people to get costs down in hospital settings, right? And I mean, there's just so many instances of that I could provide. So I'm in agreement that we have to figure out where are the unconscionably higher, and that is also, the ways in which there's been an increase in compensation for higher level people in the healthcare system, including clinicians, dare I say it, right? The increases have been dramatic, and we've got to figure out a way to address that. That's the hard work.
Thank you. David Joyner?
So the point I was making earlier wasn't to say that healthcare is like iPhones. The point I was making is that within an economy, you have lots of different goods and services that increase at different rates. And the outcome, the average per capita income is an outcome of all those things combined. And so what I'm uncomfortable with is taking that median or that average and applying it to healthcare. Because in reality, if you were to set a goal for certain things in healthcare, in the economy, you'd set some things at a much lower rate because they're going down in price, and some things at a high rate because they're going up in price. And that's the point I was making. And I'm not saying that healthcare is like iPhones. The point I'm making is that iPhones, healthcare, rent, gasoline, they're all different. And it doesn't make any sense to apply the same percentage to all of them.
Excuse me, Suzanne Rosage, then Parker, and then Ken Stewart, and then we might need to pause for a break, and also we need a public comment pause.
Thank you, and thanks, David, for clarifying, because I was actually going to say that the behavioral economics portion of it, which I thought that's where that was going, but the behavioral economics or the incentive perspective is I think needs to be partitioned out between, maybe let's use a healthcare example. Copay cards in the pharmacy world are not intended. I mean, I think they were originally, but let's just run with this. They should be for people who can't afford the medication, they're now being used as a way to hook people to the medication. So that is an incentive that helps profits, not that helps affordability. So what we're trying to do with this situation is say that this is to use the term, even a used public good, like, I don't know if this is a good example, so maybe I shouldn't step into this territory either, but you have situations like rent control, you have situations like, what did I get an email about? Internet. We started to see internet as a public good, even though prices differ. I got an email that said, make sure you submit if you have an affordability issue, we will lower the price of your internet. And so I'll stop with the comparisons as well, but only to say that there are two different worlds, right? The behavioral economics for incentives shouldn't be applied or thought about, and instead, I'm in full support of the office continuing with looking at affordability based on payment that the residents of the state can pay. Hence why I believe, and I understand the logic of household income over income or wages, excuse me. So I understand that logic, and I think the single factor, not only based on my own personal and professional approach to this, but also understand that it's simpler to be able to have one trajectory and one target that you're looking at.
Thank you, Parker, and then Ken Stewart, and then we will pause.
Well, first I'll say thanks. And when I was following the logic of the question of whether the single or combined, that made sense, but also kind of echoing the sentiment in the room as well. While I was reading this and the previous section on affordability, for me, my whole brain was saying non sequitur, because this is unrelated in a way to, I understand we're trying to, I got that the A is part of OCA and that's affordability. But it seems to me this is another issue of, to use a phrase, the cart before the horse. The biggest challenge, it seems, that OCA is first going to embrace is to get the spend. We have no idea what's happening there. And as I've been reading about the other states that have done this, the very first thing that does, the moment that you start to get that data of any bit of healthcare spend, what happens? Healthcare costs come down, or the rate of the increase decreases. Why? It's the same physics principle that we learn and whenever we took physics, right? The moment you study something, it actually changes the energy involved in it. And so to me, that's the kind of the critical piece that I got it. We probably have to set these standards and just say them. But to me, the real critical piece is to start the meat of the work and get some data on the spend. And from there, you'll be able to make better choices about, are we spending wisely or foolishly in areas? And then those would give us much better information about how to make changes.
Thank you, Ken Stewart, and then we'll pause for public comment.
Okay, so here's where I have to apologize to everybody ahead of time. The reality is purchasers and consumers, if we're talking about affordability, it's really on our end because we're the ones that have to pay for the services that we received. I recently spent one day and a night in a hospital, and it was $45,000. I didn't have any control over what was done, didn't know what it was going to cost, and the fact is that healthcare costs are basically determined by the health systems and the health plans, because we as purchasers and consumers, we're renting those negotiated rates. So I'm not blaming the health systems and the health plans, but that's the reality that we live in. If we're going to talk about affordability, it's great, and this is the first step that needs to be taken, and we have to come up with a reasonable number that's going to bend the curve. If we set it to income, well, we can see that economic conditions can totally impact that. If we look at it like in a pandemic and we see where health costs are just going out of sight and there was no control, the health systems didn't have a control over that. So I get that, but there's got to be a number that would reasonably be expected to make everybody, to me, all the stakeholders, all 5 stakeholders have to make some changes in order for us to fix this broken system. That means we all have to suck it up a little bit and just work together. But this is a good start, and we just have to be, the board's got to be rational about it. with a reasonable intent that it's going to move the needle and not get into just fighting why we're over. It's because, and we just keep going up and up and up. But this is the reality that I see that we're living in. Yeah. They didn't have my favorite television channels on the TV.
All right, we're going to pause here for a public comment period, and then we will take a break. We missed an opportunity for public comment on the previous agenda item, total healthcare expenditures regulations update. And so I would like to return to that just previous agenda item before we got into this discussion to open it for public comment. If you are in the room and would like to make a comment, please step to the podium. If you are online, please raise your hand. All right, seeing no one in the room at this time, stepping to the podium, looking back online. All right, that concludes public comment on that item. We will have a general public comment period at the end of the meeting where you could also make public comment on that item. At this point, we will take a break and return at 3:15.
Okay, everyone, it's 3:15. If you could please return to your seats, we'll resume the meeting.
I just want to make a quick note that this discussion is getting a little bit hard. It's, I think we're feeling the energy in the room, and we appreciate all of you, and we clearly have the right people in the room. So the very purpose of this advisory committee is to have a wide range of perspectives. So I just want to really appreciate, people speaking from the heart from each of your own perspectives. Please know that we're listening. I'm taking a lot of notes. Staff's taking a lot of notes. Very helpful to have Sandra Hernandez and Rick Kroenig hear this particular conversation. And it's not ping pong, but it is good to hear a wide range of perspectives. So appreciate that. Who are we off to now? Michelle, is it you or Michael or?
We do have to cover a few of the population-based measures, but Michael, you'll be up shortly. So if you could go on to the next slide. We spend a lot of time on the economic indicators. We'll be discussing some of the analysis we'll be doing on population-based measures, which is called out in the statute for us to consider as we're developing a methodology. And then on the right, the setup, what we're going to focus on with respect to the target is not only the economic indicators and population-based measures, but we're also going to hit on that bolded bullet at the end about promoting improved affordability while maintaining quality and equitable care, including consideration of persons with disabilities and chronic illness. So you'll see some of our analysis of, to what extent that may impact healthcare spending. And then, so now we're ready to hand it over to Michael for the rest of the portion.
Good afternoon, everyone. I hope you still have energy left. This is the final sprint, okay? First, I want to express my admiration for the conversation you just had. The spending target is intended to be a disruptor, and I think what you laid out pretty clearly for the board to consider is the question of how much of a disruption, right? And you vary in terms of your position, but I thought that was a really effective articulation of that question. Okay, so this last question of population-based measures is rooted in the question, are there population-based trends that would influence healthcare spending growth if we held everything else constant? Okay, and the board, when it talked about this in October, identified 4 areas of interest that they wanted staff to look at. One is they wanted to look at what would happen if we forecast changes in demographics in terms of age and sex. This is largely about the aging population. Is that going to drive spending upwards on an annual basis in a significant way if everything else was constant? 2, growing prevalence of chronic illness. And 3, changing prevalence of disability status. The 4th idea was healthcare utilization. We didn't pursue healthcare utilization because healthcare utilization drives healthcare spending. And so we get into a circular argument with healthcare utilization. And in fact, the board member who suggested it subsequently was okay with us not pursuing it for that reason. So I want to give you a little preview. We found that the impact on annual spending growth using our best efforts to project, and there were some limitations, so I want to give you that qualification, that the impact is relatively small on a year-by-year basis. Not completely insignificant, but relatively small. The other thing I want to note is aging, chronic illness, and disability status are correlated. So we treated them as independent variables, but they're not. Okay? All right, Marco, I'm going to need your help. Okay, so I'm going to go through the three population variables one at a time. The first is age and sex trends for the state. And I will note that in order, starting with age and sex, and then chronic illness and disability, actually then disability status and then chronic illness, that the strength of our analysis starts really strong and it becomes a little weaker as we go along just because the available data is more limited. But for this first question of age and sex, we've got good data. So this comes from the Department of Finance. It's projecting that over the course of the next 10 years that the population is going to age. That's true of every state in the United States. And the largest increase is in those 70 and up. In terms of the population of men and women, the percentages are anticipated to remain exactly the same. Okay, so then the next question is, so what does this change in demographics mean in terms of spending? And for that, we have to be able to evaluate what's the spending associated with different age and sex cohorts. This is something that Andrew does for a living. So I'm going to share with you what we found. Next slide, please, Marco. So we use two different data sources. The first is the Medical Expenditure Panel Survey, or MEPS. This is national survey data, and it calculates spending amounts by age and sex category. We then decided to test what we got out of MEPS by using another source. And really for convenience purposes, we looked at age, sex, weights for the state of Connecticut. Why Connecticut? Well, we do their spending target data analysis. So we had all of their weights for their state population. So we thought that would be a way for us to test out whether the MEPS data seemed to be reasonable. Okay, and when I say the MEPS data, I really mean so we're talking risk scores. So we're saying that, say, a male age 50 to 65 relative to the average is 2.3 times more expensive. Okay, that's what I mean by weights here. Okay, and I just made that up. Next slide, please. So here's what we found. We have separate analyses for the three markets of commercial, Medicare, and Medi-Cal, and these are combined. This is the whole market. So when I say Medicare, it's fee-for-service and Medicare Advantage. You see in the second column from the left, what MEPS tells us is the 10-year impact on spending growth simply due to an aging population. And you could see the impact for the commercial population quite small. For Medicare, much more significant. Overall, it's 1.6% for 10 years. Okay, not per year, but for 10 years. The Connecticut data was roughly in line. Not exactly the same, but it seems to indicate that the MEPS data is not wildly off because the differential is relatively small. So what we have in the far right column is what would potential annual adjustments to the target be if we wanted to say, look, before anybody does anything, spending's going to grow just because the population is getting older. The adjustment for the commercially covered population is really tiny, 0.02 to 0.05%, really insignificant. For Medicare, a little more, 0.3 to 0.4% is not totally insignificant, especially if we're starting at 2.8, right? And then for Medi-Cal, somewhere in between, but also pretty small. Overall, statewide, the impact would be about 0.1 percentage points a year. Any questions about this? Uh-oh. I'm in trouble.
No, I don't know if it's a question. It's just more of a comment, right? To me, it's just like, it's very intuitive that the aging demographic should be part of it. I mean, you do show it on Medicare. I guess, I don't know if there's a process to review, because, if we're actually going to be, looking at these adjustments, folks need to have transparency on the factors. We kind of be able to validate that. And the other thing is, every 1/10% counts, especially when you're compounding. And maybe it's occupational hazard. I'm looking at every cent, but just to, again, one man's opinion, every tenth or a few tenths of a percent count, right? Because that's actually real. People are aging. Resource intensity goes up. So.
Right, and because the spending target in time, not initially, is going to be used for accountability purposes, we want to be fair, not hold people accountable for something for which there's no control. Okay, so let me go through the next two variables. Yeah, and then we'll talk about what do they all mean when we put them together. Okay, so next is disability status adjustment. So as I said, the strength of the data that we have to support each of the adjustments gets a little bit reduced as we go on over time. But I think what we have is good enough to share something with you. So, first, what we are using here is the American Community Survey, which is a Census Bureau survey. And it's an enormous survey, gets a high response rate. For 2021, it estimated that 11.2% of Californians had a disability. There's a limitation in the survey for data analysis purposes in that it's self-reported. Now, that's not a problem in and of itself. It's just that we can't then go into a claims database and verify it because first of all, claim data is notoriously terrible at identifying disability status. But we don't have any other administrative source of finding data to verify what's reported. So we just have to note that that's what we have, and so it's hard to tie it to administrative data sources. Next slide, please. So we looked at two studies that used MEPS data that developed estimates of the difference in spending for people with disabilities and without disabilities. Now, one of them found a differential of about, rounded, 4 times, and the other one about 5 times. Okay? They did not generate estimates by market. It's just total population. So that's a limitation here. And as I noted, these variables are correlated. You are more likely to have a disability if you are older. Okay? And we're not controlling for that. So do not think about the data I'm sharing here and say, oh, well, I'm going to add that to the percentages that we just saw in Asian sex.
What's the definition of disability again?
So this is survey data.
Chronic disability?
Yeah, so it's determined by the questions in the survey, and I didn't bring the questions, Ken. Okay. So I apologize. That's fine. Yeah, there are terms that help define what it is, but ultimately it's a self-assessment by the individual completing the survey. It's not a blank question, do you have a disability or not?
For the record, the question was, what's the definition of a disability? We just need to have everything in the microphone. Right. Thank you.
Yeah. Yeah, as used here. Okay, next slide, please. All right, so overall disability prevalence in the state was over about 11 years or 10 years was increasing 0.1% a year, okay? Very small increase annually in disability prevalence. Now, here I'm using historical data. You might recall with age and sex, I was using a forecast from the Department of Finance about where they saw the state population going. This is not a forecast of what's going to happen with disability prevalence. This is an observation of what was happening. So I want to call out that difference. The impact on annual spending you can see here. We've estimated it by market. It's actually a little bit more for the commercial market than for Medicare and Medicaid. So it's, 0.2, 1.1, 0.2% a year. For Andrew, who's counting every penny, that's a lot of money, okay? But overall, it's a relatively small impact on spending growth, holding everything constant.
Again, this is pre-2020, right? And I seem to be reading that there's just a lot of, and seeing that there's a lot of COVID-related disability. Like after the pandemic, has it doubled, do we think? Or I don't know.
So this is through 2021.
Oh, it is?
Yeah, so
but the reported, the like extended picture of that has changed, right? Like a lot of that was thought to be short-term and...
So I'll share with you, I don't have the data here on the slide, but when we look at the data from 2010 to 2021, it's strange. In 2010, 2011, there's a jump up in prevalence, and then it's pretty flat until you get to 2020. There's a big jump up in 2020, and then it came down a little bit in 2021. We don't have 2022 yet. So we're saying that the prevalence was increasing 0.1% a year, but it is not a flat line. That's us averaging some really bumpy data. That includes COVID. And if anyone wants to ask, and what's going to be the impact of long COVID, I can't answer that question. Okay. So again, these data are not quite as confidence building as the age and sex data. I don't think they're bad. They're just not as robust. Okay. All right, let's do the third. Oh, I'm sorry. Any questions, other questions about this?
Carolyn Nava, go ahead.
Perhaps not so much a question as a thought. Working in the field of disability, none of this data sits well with me. Number one, I work daily in a region where comparative numbers are astronomically larger than this in this state. So maybe this speaks back to our previous conversation about the challenges that come perhaps with aggregated data, but I did hear you say that there was really no point of comparison for some of this information. So I'm curious because I do know that there are organizations that collect this type of data consistently multiple times a year, like the Department of Rehabilitation, like the Administration for Community Living on the federal level. So there are entities out there where we could do that cross comparison to see if this 0.1 is really a staple.
Yeah, but I don't think that they collect it for the whole population.
Okay. As in the whole population with disabilities, or just the population,
the whole population
at large?
State, right? Because what we're trying to assess here is the prevalence of disability in the whole state. Well, in this case, has it been increasing? But what we really care about is projecting, will it be increasing?
Yeah, and I think that's where it kind of isn't settling. And I'll give it some more pondering. And as I was reviewing it in preparation, I thought this just doesn't feel right. But I think too, if you add in the demographics to this 0.1, we've been talking consistently about the data that's not here in the conversation. And I can tell you that a lot of it's not here is because you're dealing with people with multiple layers of disabilities who don't qualify for other services, who can't, for example, get into the programs where they might get help due to we're on the margin economically, or we just don't even have the wherewithal to get through the gate, so we're paying out of pocket. We have no monitor for this. I think that's been my biggest challenge is sitting here quietly listening and hearing the same thoughts come up and feeling like we're not getting any closer to addressing some major impacts on this data and these decisions moving forward. So it's just a thought, but I was curious, making sure I was clear on that comparison when I do know there are entities gathering that data.
In terms of getting an estimate of statewide disability prevalence, as far as we were able to determine these are the best data sources we have right now, not saying they're ideal.
Okay. Yeah, I was just curious because I know this is basically coming from the Department of Public Health, which is just one snapshot of what's available out there. And that's where the thought was coming from.
Yeah, these are both two federal surveys that I've described so far.
Okay. Maybe I'm misunderstanding.
And so they
saw
do
UC Davis
they do a very large representative sample, and they develop estimates for the whole state.
Okay. I'll dig a little deeper. I just wanted to query that.
All right, and one additional comment or question, Joan Allen.
Yeah, I'm just thinking about, is a disability diagnosis is the wrong word, but determination is definitely one of the things that will make people churn from one health coverage to another. Generally from commercial toward Medicare or Medi-Cal or dual. Do you have any sense of how that churn impacts this entire conversation? Darn, I was hoping you had a magic data source.
Sorry.
So you are shaking your head no. Is that correct? Thank you.
That was a no for the record. Okay, let's go to chronic illness adjustment. So here we have only one data source, and but it's California specific, so that's good. The Department of Public Health and UC Davis looked at change in spending over several years for patients with 6 chronic illnesses. And you might say only 6, but if you look at what the 6 are here, they account for probably the vast majority of spend for people with chronic illness. They estimated savings using MEPS data that was fed into a cost calculator the CDC developed. Here again, we know chronic illness prevalence is correlated with aging, that it's also related to disability status. The data that we got through this analysis was not disaggregated by market. Next slide, please. So we had to ask 3 questions. How did prevalence change? In this study, this one study, there was an observed weighted average increase of about 1.6%. And spending overall, as a percentage of total spending, because that's the only data we got out of this survey, grew about 2.1% over the 6 years. So our estimate, and this is the one I feel least confident in of the 3, is that the annual impact on spending would be 0.3 to 0.4 percentage points. Okay, now that's larger than for the other 2, but again, my confidence level is the lowest for these 3.
We have two committee members attending virtually with their hands raised. So I'll start with Eliza and go to Mike O'Day.
Thank you. Both on the disability and the chronic illness.
Eliza, we can't hear you at this point. Can you check your microphone on your end?
Okay.
I'm sorry, we're not able to hear you just yet.
Keep going, I'll check.
I'm sorry. We will move to Mike O'Day, and Eliza, we will try and get back.
For what it's worth, this is Rick. I can hear Eliza.
Mike, go ahead. I can see you need to unmute on your end.
Yeah, I can hear Eliza too. Can you hear me?
I can't hear you either. It's a technical glitch in the room. Yep.
Yeah, Mike, I can hear you for what it's worth.
All right, we will come back to you in just a moment. At this point, we'll ask the presenter to go ahead and come back to your questions in a moment.
All right. It's like
I think we can hear each other, but that's about it.
Thank you for the presentation. I mean, I think when, trying to figure this out, I think, simplicity is a starting baseline, and the question is um, when taking into account these adjustments, are they useful enough and meaningful enough that they're worth the effort to determine them, or were we getting to some sort of false precision with regard to them? And I think I would also, when we look at these are relatively small. I appreciate every bit matters, but they are relatively small. They also are, at least certainly for aging population, but also for disability, they are costs are largely borne on public programs. On aging, that's really on the Medicare side. Even disability, I think there's studies that suggest that 70% of those costs are borne by public programs, and so this is less in the realms of the areas that we're trying to affect with this project. And then my concern with the chronic illness is as what we discussed in some other forums as well, the gameability of it, which is to the extent that these are that the way these are reported, that they are potentially gameable, and that while my instinct would be yes, taking into account some of these factors might actually bring us to equity, closer to equity, it actually might have a reverse equity effect, because people who use care more tend to be the people who have access to care more, who tend to be folks who are more in better positions to get care, and so I just want to be cautious of that. So I think there's some countervailing forces that I wonder if getting to these sort of fairly small changes is worth it, given again the fact that either these costs are borne by public programs, or we start to lose confidence when you take into account a range of other factors. And so at some level there is a question of is this worth making this target setting more complicated than it's worth?
Thank you. Returning back to our virtual attendees, Eliza and then Mike O'Day, we should be able to hear you now.
Thank you. I have two questions. The first one relates both to the chronic illness and the disability. And the question
I'm sorry,
is,
Eliza, we are not able to hear you. This is a technical glitch on our end that we are working on. We will come back to you. Going back to the room, Andrew C.
Yes, so I guess is the juice worth the squeeze? I think the answer is yes, right? So I think first off, it is true that people are getting older. It's more resource intense. We're talking about total cost of care, right? It's payer agnostic at the end of the day, and the clinicians do not treat people differently by line of business, and we don't really want to create incentives for them to do that, right? So I think there's, and also I think again we have to have transparency on methodology. All due respect to Connecticut, lovely state, it is not California, and healthcare is famously local. But I think that it's the question. I think it's pretty self-evident. People are aging. We can come up with an adjustment that's not gameable, right? I agree with you there, right? We can't get into coding games, but age, gender is kind of pretty solid, and as long as we can come up with a transparent methodology that everybody can buy in on, I think it's a pretty worthwhile adjustment. And the whole thing is complicated, by the way, because we're factor number 2 of a very long list over 2 meetings. So I mean, simple kind of left the station a while back.
Yes, Karen, excuse me.
I think I have some overall concern with these population adjustments, because while I understand that, of course, people's health conditions become more complex as they age, if they have a disability, et cetera, and there's costs associated with that, again, going back to the goal of reducing costs, I don't think we should assume that because these factors are associated with these cost increases now, that's what the target should be. And in particular, I think things like our older adult population and the services they need actually present some real opportunities to lower costs, right? We're providing
pretty poor quality, pretty high cost services right now with a lot of institutionalization. Same thing with chronic illness. There's a lot of opportunity for the healthcare system to do a better and also less costly job to both prevent chronic illness and treat it. So I would be worried about taking those numbers and saying, hey, here's how they impact costs. Here's how these population factors impact costs today. So we should factor in that full amount. I think at the least we should be looking at how do we want to, as the state of California, set policy that reduces that, that drives changes in our delivery system that ultimately result in better care.
Thank you. Suzanne, usage?
I just echo now that Kieran shared that, what Kieran said, and go back to the idea of if we're the bar conversation, if we add percentage points on something that we don't know for the future, then we're really just lowering the bar before the bar is set. And so I also echo the idea that Anthony shared of adding in layers. I don't think the juice is worth the squeeze because we're squeezing right now and there's really not any juice coming out. And so I look at it from a completely different perspective of we actually need to change things. So like we are not in the room to solve for what the actual change to the healthcare system is. Some people in here can, but that's something that will happen later. So if we use yesterday's or, like Kieran said, today's metrics, then we're losing sight of the fact that we should be living in a completely different world, and we're trying to open that door.
Joan Allen, please go ahead.
I'm going back to something that Parker said earlier in the day, talking about how much more we're going to know once we actually start to get the THCE data coming in. And we're actually going to be able to see into at least some of these with real California data. And so it feels premature to be adding these in now. When we're going, the first target we're setting is a measurement target rather than a compliance target. And so we can wait, we have the time. And so it seems worth going with simple now and then seeing if down the road we need to add complexity.
Joel, let me just clarify. These data, we're not going to get through the THCE submissions. So
some we will. We'll get age and sex.
Age and sex we will. But,
and age and sex, as we know, have a lot of correlation going on.
But we won't get disability prevalence, and we won't get chronic illness prevalence. Chronic illness prevalence we can probably get out of the HPD someday. But I just want to clarify, those two we won't get out of the THCE submissions.
Right, but we'll have a lot more information than we have now.
Yeah, so. Well, particularly on age and sex.
Yeah.
Okay, any other comments or questions in the room? Yes. Mr. Arbuckle.
This hasn't been mentioned yet, and I'm still thinking it through, but I just wonder if we should unpeel the onion a few layers. I noticed these reports on both disability and chronic illness didn't touch race and ethnicity. And given that with disabilities, the difference in the races is upwards of not 0.1, but 50% between disabilities. And with chronic illness, it's 300% between certain races. Need that be measured? Now, I know we're looking at change year over year, so you might argue that's going to be more along the lines of these 0.1s and whatnot. But a few of us in the room are old enough to remember the introduction of Medicare Advantage when it was called Medicare Plus Choice. And there was a significant flight away from communities that had a higher burden of both disability and chronic illness. And I just fear that unless we measure or look at that in some manner or form, we may be setting that up. And again, I'm just thinking through this, but it's just pondering that thought.
Yeah, although remember, the spending target is assessing not total spend, but change in spend over time. So it's a little different than the Medicare program.
But if you were at an organization, whether it be a health plan or a provider, at risk of exceeding your benchmark, and you could begin redirecting your services away from certain communities, you could reduce your spending plan that way.
Right.
I don't want that
Yeah.
incentive.
So there are future conversations to be held about equity adjustments, which we're not ready for today, but we will be talking about that.
Fair enough.
Yes, Stacy Hurons.
I actually concur with the recommendation for further evaluation and use on this, on the population health targets.
Thank you.
That's the next slide for people who haven't looked at it.
Okay, Michael. Michael, back to you.
No, you stole Michelle's thunder. I take it.
Oh, that's a good segue. Yeah, so we discussed this issue. The same set of slides were presented to the board, and at the time for that meeting in October, we said that we advised the board that further analysis on the use of population-based metrics was needed, and we definitely got a lot of feedback today, and we'll be communicating that back to the board. We do want to note that no other state has incorporated population-based measures and adjustments, and then do want to flag that these, just based on our analysis included in this slide deck, the adjustments would be minimal. Before we move on to it seems like we did have a robust discussion on this issue, so I do think we're ready to move on to the next portion of the agenda, which is multi or single year target setting. Similar to the other slides, we're bolding the requirements we're hitting in statute about the target being predictable and sustainable rate of change, and that it could be set for each calendar year with consideration of multi-year targets. And then turning it back over to Michael to talk about other states.
Thanks, Michelle. So this slide here shows you the duration of the spending targets that were set up in other states. You can see they're all clustered, and more states than not have done 5 years when they set them. Massachusetts is an outlier at 20 because that was in statute when their program was established. And Oregon set one value for 5 years and then another value for the second 5 years. But every one of the states has selected multi-year target values. Okay, that's the key takeaway. All right, so let me present 3 questions to you. The first one on the next slide is.
All right, we need to pause at this moment and go back to our virtual attendees that had comments or questions a moment ago. So I think we've fixed that technically. Sorry to interrupt you. Let's go back to Eliza and then Mike O'Day. Eliza, go ahead.
Can you hear me?
We can. Wonderful.
Okay,
Thank you.
Perfect. Hi. So 2 quick questions. The first one, I think it was Barry talked about the equity adjustment. So glad to hear we're going to look at that. But the question was, is there consideration for including virtual care spend and non-traditional providers now outside of brick and mortar that have begun to render services, especially in underserved areas and rural areas? Is there an adjustment contemplation for that?
All right, so I heard actually 2 questions. Are we including those services in total spend, and is there an adjustment for them? So I'll let Vishal answer the first question, and I'll answer the second one.
To the extent that they're a covered benefit by the health plan, it would be included. And then the second question is about adjustments?
Adjustments. Okay. So the adjustments that I just presented were the ones that the board asked us to research. Okay, that's why we looked at those. They're in statute. Well, the statute says population-based measures. They selected, age, sex, chronic illness, and disability status. So that does not mean that possible population-based measure adjustments are limited to those. If any of you had a recommendation for another one that should be considered, you can share that to be shared with the board. But the reason that I just shared the information I did with you is because the board asked for that information.
Yeah, so I would offer that perhaps a recommendation be made to the board to look at underserved areas and rural areas as potential contemplation.
Thank you. Moving to Mike O'Day.
Hi, can you guys hear me?
Yes.
Great. Thanks for the presentation. I had a question looking at the chronic illness adjustment data and wondered if that included oral health, because in addition to asthma, cavities or dental caries are the most common chronic disease for kids. So wondered what the, how we're incorporating the spending on oral health and dental.
Yeah, thanks for your question, Mike. So this particular study that was done by the Department of Public Health and UC Davis did not include oral health as a chronic illness. Okay, that's not our methodology, that was theirs.
Thank you.
Okay, so why don't I go back to the 3 questions that have to do with the duration of the target. So the first question on the next slide, Marco, if you would, is 1 year or multiple years. So 1 year is nimble. You can make an adjustment each year to account for macroeconomic changes. The con is it's time consuming to set target values every single year. And if you're setting it every year, you don't really have some sense of how do we perform against the target in prior years, because it takes, there's a long tail between the performance year and when you report it. Basically, you're reporting 2 years after the performance year. Multiple years, the strengths of this is it tells payer and provider organizations what they're working towards, so they have advance notice. And there's some value in knowing what you have to work towards. And it promotes, in general, predictability and sustainability. And those are some statutory concepts that Vishal shared a minute ago. The downside, of course, is we don't know what the future holds. When all the states set their targets in 2019, they didn't know what was going to happen in 2020. Okay? And so that doesn't mean you can't manage around that in terms of how you interpret your results. But the longer duration of your target setting, the greater the risk that unknown events are going to drive spending either up or drive spending down. Okay. Anybody want to share any thoughts on this question? Okay. So question number 2, again, there are 3 questions. So if we're setting multi-year targets, I'm not presuming that that's what you think should be done or what the board thinks should be done, but if setting multi-year targets, for how long? So 2 to 3 years is one option. You'll note the other states were all 4+, but you could have them shorter. Contracting cycles between health plans and providers are often 2 or 3 years. The con of this is if it's 2 years, we won't know the results after 2 years. And we're only going to get the results in the 3rd year. The longer duration gives more time to make changes, can assist in strategic planning. But again, it leaves us more at risk of there being big changes that occur. And we would have to find some mechanism to account for that retrospectively.
Yes, Janice, please go ahead.
It seems pretty remarkable that Massachusetts has their target duration for 2 decades. Do they make accommodations for certain
so I should put a little asterisk by that. So what really happened is they set the initial value for, I think, 10 years, and then they said that the Health Policy Commission, which is the state body that has jurisdiction over the program, can adjust it. And in fact, they've adjusted it twice. Okay. So they established a program for 20 years, but really they only fixed the value for 10. Okay. And this is a good example of the unknown. We were talking about Sovaldi earlier. So Sovaldi came out in year 3 of their program, and their spending shot through the roof. And their Health Policy Commission said, it's okay that we did not hit our spending target this year. We know exactly why we didn't hit it, and we're all okay with that. Okay, and question number 3. I can feel the energy levels dropping around me as I speak. So the third question is, should the value be fixed or should it change over time? We use the term here, phased in. So Rhode Island, when they set theirs, they said initially 3.2% for 4 years, that's it. But no other state has done that. Well, Massachusetts was fixed for the initial 10 years. But the other states set it at one value, and on some schedule, it was phased in. It was always phased in, so it started higher and dropped lower. Could you start lower and go up? Yeah, you could, but nobody's done that. Okay, and I think generally when it started higher and dropped lower, it's to address some sense that this is going to be hard, and it will be easier for provider and payer organizations if it starts a little above the desired long-term goal and then comes down. Whether that's been the case or not, I can't say, but I think that's what the policy intent was. So the phased in addresses that concern. It's a little harder to communicate, right? If you have a schedule that says, well, the value's this year and that year, as opposed to in Rhode Island where they just said 3.2%. Everybody knows what 3.2% means in Rhode Island. So that's the trade-off. You get more complexity with a phased-in approach, but you might make it easier to implement for the organizations that are going to be directly impacted by the spending. Okay, so those are the questions. I think, Vishal, now it's your turn.
So at the October board meeting, this is the staff recommendation we provided. We recommend initial targets should be set for 5 calendar years. For example, 2025 through 2029. This would allow the industry's time for sufficient planning. And then after the first annual report on calendar year 2026, which is the first enforceable target, is released in 2027, the board will have an opportunity to review the effectiveness of the target values and compliance. So they'll always kind of have an opportunity to gauge and assess whether the target's going to be met and potentially make changes. The target value should be phased in over 5 years, progressively decreasing and then remain fixed. I do want to provide what the board offered for input to the staff recommendation. One member expressed support for an initial 5-year duration for the target. Others did not comment on, the length of time for the target setting. 3 members suggested no phase-in. That is, there should just be a flat target for the 5 years, while another member suggested a 2-year phase-in. And then another board member said he would need to know what the target value, they would need to know what the target value is before weighing in on whether to phase in. Yeah. So now we could take your questions or input.
I see Suzanne usage.
I think specifically to that, I would almost answer the same to wanting to see the target value, because I think I'd have a black and white answer to the second major bullet, whether it's phased in or fixed. If it was 5, which is the agreed upon number, and then were to go down, but that doesn't sound like phased in. So I think I'm going to assume my initial answer was, I think it needs to be fixed, mostly because there's an expectation that, or rather, there's always the opportunity, like we were discussing, that if there's unforeseen circumstances or things that people were not able, entities were not able to prepare for, and that can always be taken in consideration. But I don't think that even though this law passed a while ago, there's been the expectation that it's coming. I don't think there's the same consideration for the affordability part of it, right? The consumer part of it. There's not that phase in, and just looking at, and I think we we're talking about with a couple of folks earlier about, and Samana mentioned it for her own personal coverage, is that, you know, our plan is seeing a 25% increase year over year. Last year was 18%. And granted, I will acknowledge that we saw costs go down in 2020, but I do think that the costs in the healthcare system also went down, and that's considering a few million dollars of inpatient claims for COVID patients. And so net, we were down in 2020, but that was the only year. And since then, our trend has gone much higher in 2020, into 2021, into 2022, into 2023, and now into 2024. It's even higher than those prior 3 years. And I know that I'm smaller, and so you see peaks and valleys a lot more. But I think there's just one anecdote to support that doing a phased-in approach doesn't actually solve the problem earlier. And I think there's enough information out there to start seeing where we can hit the target. So I support the 5 years, if that's helpful. But then I think, even though I wasn't clear with my first answer, I think if the target value is at a what the recommended is, if it were something like 5, then I think it should be fixed.
Thank you. Ivana Krasunovich, and then Sarah Sorokin, and then Andrew C.
I feel like people already have kind of a phase in because it's taking a while to set up and to be effective. And I feel like our rates are already going up because providers know that at some point there's going to be a cap, right? So I don't have proof of that. It just feels that way to me. So I feel like the longer we put off getting to where we need to be, the worse it is. So I'm okay with the 5 years. I think that makes sense for planning. But I think that, you know, the only way I would consider supporting a phase-in is if the goal was super, you know, ambitious. Like 3.2, I was like, all right, like we can start with 4 and go to 3.2. But if we're at 5, like I don't want to start above 5, you know, because we can't wait for this relief.
Sarah Sorokin.
My comment is just basically the same as Ivana and Suzanne, that it seems like we already have a mechanism in place if people do go over the spending target to see why that was and make an exception if it's a valid reason. And I am also concerned about gouging in advance of the target being set. And so I support the fixed and the 5-year for planning as well.
Andrew C.
So I guess I support the 5-year target, right? It makes sense just for planning because contracts are multi-year, right? Provider contract, labor contracts are all multi-year. I guess not knowing the number, I'm team phase in. It's really the same logic, right? You have provider contracts and labor contracts that are fixed. It'll take a while, and you just really have to phase a big change in because you really don't want to shock the system.
Joan
Allen. I would encourage us to look toward a 4-year initial because there is a deadline in the statute of 2028 to start setting sector targets. And that is that as of June 1st, 2028 or earlier, the board will have begun to set sector or entity specific targets. And in that sort of crawl, walk, run, this entire multi-year initial phase that we're talking about is the crawl phase, whether it's phased in or fixed. And then we're going to get to those entity specific or sector specific targets that really can help us drill down on incentivizing places where we need to invest while going after high cost outliers. And so until we're getting to that adjustment, we're still in that crawl phase. So I'd shorten that crawl phase and pull forward by a couple months that June 1st, 2028 deadline, because right now there's a mismatch where entities have to know their target by March 1st of the previous year. And so if we wait until June 1st of 2028, then we won't get to sector targets until 2030. Whereas if we do that just a couple months earlier, we could get to sector targets in 2029 and really get to the meat of using this to help really reform the system.
Anthony Wright and then Abby Yant.
Yeah, just to put on the record that for some of the previous conversations, I was for the median income. For this one, I am for. I appreciate the desire for some multi-year targeting because there is fluctuations year to year. We see that in covered California, where there's 1 year's an adjustment from another year, and so I don't know if I have a crystal ball of should it be 3 or 4. I do think that it's you want to make it so that there is a balance. There is a real tension here about the longer you make it, it does allow for some smoothing. It also allows for harder to hold folks accountable because it stretches over time. I think the area where we do have a strong reaction is on phase-in. Not taking into account all the many years of conversations to even get this, passed, which started when my kid was in grade school, but this was enacted in 2022, and enforceable targets don't go into effect until 2027. So that's already a 5-year phase. And if we added another 5 years, my kid would be well into grad school. And I think we might be even like 2 governors from now. So I think we should just recognize that just even the processes of government, if you want people to have confidence in a program, you have to sort of say you have to be able to point to this is something's coming from it, not that something's going to come from it in literally 10 years. And so I just want to acknowledge that I think we have other mechanisms to take into account the real accommodations that need to be made over a piece of time.
And beyond.
Yeah, I just want to speak to this as a public employer. Our budget cycles are 2-year budget cycles, and so predictability is incredibly important. And that's why the pain that we felt this last year was enormous, because it came very late in the budget cycle and really impacted the entire city budget. As our surprise was 71 million. So that you can imagine that how the impact that had on other services that we provide. And so I think the need to have some predictability to this sooner is really important. And generally speaking, I don't know, I live by rules of 3, and business cycles are pretty much rules of 3. And if we did a 3-year phase in, I think that would be very suitable. But as far as the target itself and where we start is, I think, what's the most sensitive piece of information here that we're discussing. Is it 4? Is it 5? Is it 7? Is it what? I think that is where we need to come to terms with what that really means for our purchasers. The cost is just at a point where it's breaking everything around us. So I think we have to be very aggressive.
Any other comments, questions, feedback? Michael, anything more from you?
Yes.
All right.
But this is the last, okay? And you won't see me until 2024. Okay, so last topic is whether to adjust the target or not. And Vishal's going to give you the statutory basis for this conversation, and then I'll describe the issue a little bit more.
So I covered this at the top of this agenda item about the factors to adjust future targets. That's not the full list, but we just call out a few examples that we need to consider, which are healthcare employment, cost index, labor costs, CPIU, and other factors. And then on the right-hand side for target, there is a requirement that the target be updated periodically and consider relevant adjustment factors. And then back to you, Michael.
Okay. So I'm going to start by sharing with you what other states do. The practices are highly variable. So in near alphabetical order, Connecticut has in their methodology has language that says that they may revisit their methodology calculation should there be a sharp rise in inflation during the period of their initial benchmarks, which you see here. In Delaware, the state's finance committee every single year reviews their methodology, and they may change the target if the long-term economic forecast changes in a material way. Long-term forecast. In Massachusetts, the value was set in statute, but as I described just minutes ago, in response to your question, the Health Policy Commission can modify the value, but with the approval of the legislature. In Oregon and Washington, there is no official adjustment at all. But that being said, they did consider their methodologies when inflation bumped up in 2021 and 2022. And finally, in Rhode Island, they have a provision that, quote, highly significant changes to their economy can trigger a revisiting. Okay, so in most of these states, there is some escape door where there can be a review, but not in all. And the criterion that triggers the review is variable across the states. Okay, next slide. So yes, no question, are there conditions that warrant revisiting a target mid-year or mid-cycle? The yes argument is external events can impact spending, and it's not fair to hold plans or providers accountable for things that they can't control. The no is that certain events can trigger spending growth, but that spending growth is a burden on consumers. And yes, it's going to hit spending costs, but every time there's something that might jolt healthcare spending, it's not fair that the consumer has to suffer for it. So those are pros, cons arguments. I'm not going to argue for or against them, but those are some ideas for you to consider. Any questions before we discuss the merits of whether or not to have a provision that allows the values to be reconsidered? Okay, Michelle?
So we did not offer a recommendation regarding conditions that may warrant adjustment to the target. And board members also didn't offer a comment when we presented this question. So it's returning the floor back to the advisory committee if they have any feedback on this issue.
Ken Stewart, go ahead.
I think unless you have teeth in the underlying document to use if needed, there's going to be a problem if something comes up. Therefore, I think there should be room for a mechanism for making an adjustment if necessary.
Stacy, go ahead.
Ken and I concur with each other. We think that the board should have the ability to make an adjustment based on what's happening in the world in healthcare.
Sarah and then Barry.
Is there a way to put qualifications on adjustments? Like if, let's say, like in the case of the COVID pandemic at the beginning, if the government is going to provide funding to offset costs, then that shouldn't be considered, reason for adjusting the target because that extra money is coming in, or if there's limitations, or maybe make limitations based on like how much costs the consumer will have to brunt, like, oh, the consumer can't, take more than this percentage, or I mean, ideally none, but like make limitations on or qualifications on changing the spending target.
Thank you, Barry, and then Joan.
I agree with the comments from Stacy and Ken about empowering the board to be able to adjust the spending target based upon factors that occur. I mean, they're in control of how much it's done, if it's done at all, with input from staff. Not to do so in the event of something that would realistically warrant doing so is going to flood OHCA staff with appeals when multiple entities, payers, providers, et cetera, exceed a target for reasons that on the surface look pretty justifiable, like a major pandemic. And why set yourself up for that? I mean, give the board the power to make that decision based upon everything that they see at that time.
Thank you, Joan, Ivana, and then Andrew.
Two things. One, the board already has the power to make adjustments because if an entity misses their target, they have the ability to waive penalties essentially and not pursue penalties. And we saw that happen in Massachusetts, even when they were in the window where they weren't allowed to pursue a change. They gave everybody a mulligan for Sovaldi. And we would expect the board to have that same level of understanding of large-scale events. That being said, I don't actually mind there being the ability for the board to adjust the target. But in both of those potential adjustments, whether it's a global adjustment or individual adjustments, once entities have missed their target, would just argue for as much transparency as we can get. That if we are going to give increases and create room under the cap, because let's be real, we are talking entirely about upward adjustments. We're not talking about if in the future interest rates go back down that the target's going to get adjusted down. I don't see that as particularly realistic. And so we as the consumers need as much information as possible to understand why the board is giving those adjustments.
Ivana and then Andrew.
I think again, it kind of goes back to what the target is. If it's a really aggressive target, then I feel like, yeah, the board should, I agree with what a lot of people have said. I think there should be flexibility. The question is, on the one hand, you don't want there to be a ton of appeals. On the other hand, if you're not really clear about what the target is, then you're going to have people feeling like, they're going to adjust it. Don't worry. There's adjustments. Don't worry about it, right? So I feel like it's got to be a combination of like, if there's a really aggressive target, then the sense that there will be adjustments. And the language is interesting, like Rhode Island saying that it's significant changes in the economy, which is different from like just inflation or something like that. So I think that how that is phrased is really important, but it's got to be seen together with the target.
Let me clarify, just because there seems to be a little confusion on this. When we're talking about adjustments to the spending target, it's not a retrospective assessment of should we give Andrew permission for exceeding the target. This is about setting a target for 5 years and then saying in year 3, our state level target we want to modify.
Andrew and then Carmen.
So I think I like that clarification, right? So I'm, of course, yes. And the timing of the adjustment matters, right? Is it a prospective adjustment or is it after the fact? Because if it's an after the fact adjustment, just think about breakthrough innovation, right? So you'll have a drug cure something, right? And, you're staring at a target. No one's told you can exceed it. It creates weird incentives on the part of payers, right? What incentive are we creating at that point? So I think that the timing of the adjustment matters, but yeah, I guess it's yes.
Yeah, we have not talked about this yet, but I think we should presume that there will be some retrospective process in addition for things that are unanticipated, where OCA will need to retrospectively assess whether organizations exceeding the target did so reasonably or not.
Right, acts of God, right? Let's just call them acts of God after the fact. You can't predict that, but I think.
Or a pharma.
Right? Pharma, I don't know, because and pharma is a little bit interesting.
No,
right?
But Sovaldi, okay?
So.
Right, Sovaldi happened during the year. Nobody knew prospectively that it was going to happen.
Yeah, I'm trying to stick to just the comment on the prospective adjustment, because I do think at least retrospective adjustment is really important, that at least on the individual level that we understand why, like there may be a request for a retrospective adjustment, and that can't happen without, as Sarah was saying, without any qualifications. But on the prospective adjustment, I think, when I saw that some of the other states were just like, if there's inflation, like, well, inflation happens a lot. Like, why is inflation happening? Are we getting into the cyclical kind of setting where, you know, prices go up in the healthcare sphere and then that causes inflation and then therefore they get, you know, there's increases in the spending target and then there's more inflation and like, we don't want to get stuck in there. So I think it's important that at least when allowing for adjustments prospectively is that we're very careful to make sure that it's, you know, it's actually an act of God or and with the caveat that pharma is not God. So, you know, I think I think we're all it's getting at the end of the day. You know, you all know what I mean. But I think it's really important to understand that it's not, you know, it's not, we're not allowing pushing upwards through the adjustment process itself.
Yeah, I can't claim that I know, you know, the different things that might happen over the course of us setting the cost targets and what pharma will do to these cost targets. But I would exercise caution when we talk about economic factors, because at the end of the day, this is about the consumer affordability piece. And so if we adjust for inflation, we have to also recognize that inflation hits the pocketbooks of many of our consumers. When we're talking about a recession, we're talking about major impacts to families. And so, you know, I don't know what the answer is, but, you know, obviously I would hope and expect that the OCA board will recognize that as well.
You know, I'll note on this point of inflation, so obviously inflation jumped up, and so every single state that set their target values before it went up had to make a decision, do we want to make a change? Knowing that there's research that shows that increases in inflation ripple through into healthcare spending, not right away, but usually with a couple-year lag, which is what we've seen. None of the states adjusted their spending targets for the reason that you just identified. I'm not going to say whether that's right or wrong, but that's what happened.
Ken Stewart, please go ahead.
I think we're talking about hypotheticals, and we really started this out by saying, should the board be empowered to make a decision to make a change if deemed necessary? We can cover a million different scenarios, whether it's looking forward or back. I think it should just be very clear that yes, in the board's discretion, I trust them. I hope we all trust them to make a prudent decision, and it's a business decision that we should empower them to be able to make.
Stacey Hernandez, please go ahead.
Michael, the targets that have been set in the various states, what percentage of the providers met those targets?
So we've had some funny years recently. So in 2020, everybody met them. In 2021, not one met them.
Right.
And in the years before that, it was mixed. I will note that while there are a whole bunch of states that have these programs, the number of programs that existed pre-COVID, very small. Mm-hmm. So we don't have, except for Massachusetts, we don't have a long track record.
What happened in Massachusetts? Did pre-COVID?
So interestingly, Massachusetts does not publicly report each year on who met and who didn't. Okay?
Do they report like a percentage of the
They report their statewide rate, but they do not make a big deal about who passed and who failed, so to speak.
So what percentage was it?
I don't know.
Oh, on a statewide basis.
Oh, on a statewide basis? So for the first 6 years, Massachusetts, on average, including the Sovaldi year, met its target, which was set at, I forget now, 3.6, 3.7, something like that. The last couple of years, Massachusetts has blown through its spending target. And for that reason, the Health Policy Commission this year has recommended a whole host of new legislative actions, because in their eyes, the initial power of having the target and having a big public hearing process every year, that was enough to slow spending growth. It clearly looks like it did impact behavior, but the last couple of years, it doesn't look like it has.
Thank you.
Yeah.
Anthony Wright.
I was going to say something else, but just in terms of questions, I mean, I thought some of the narrative from Massachusetts was that them setting a goal, just the fact of setting the goal and having the transparency that Parker and others talked about, had that sort of salutary effect, and that part of that was sort of the naming and shaming of outliers that were popping up, partners, you know, but are you saying that like that was done more specifically rather than broadly?
So they went and talked to all the organizations that exceeded? Individually, but it was behind closed doors conversations with them where they said, what's going on here? But they did, I mean, every state's ecosystem is different.
Mm-hmm.
I will also note that when Massachusetts created the legislation setting up their spending target, it preceded a series of high-profile stories in the Boston Globe about partners and how they were driving up spending for the whole state. So there was a lot of sensitivity in the delivery system about the fact that people were being named and shamed above the fold when people were still reading newspapers. Okay, but that influences the impact of the program.
Right.
And I will share with you that in some of these states that were the early replicators, so this is Delaware, Oregon, Rhode Island, the same dynamics didn't play out because the environment wasn't the same. So can there be an impact if there's lots of visibility and lots of publicity about performance and attention? Yes, but it's not that way in every state.
Thank you. To the question, I think, as is stated, I do think that the board like practically has this power. So whether I would recommend it to them to have it or not, is sort of a moot point. Like I think they have, like practically or not, they can, you know, even if we don't officially give it to them, they could just go through a process to reset a decision they made before, right? So I hope that if the recognition that they can make adjustments then empowers them to be more aggressive about a target, that they don't have to take into account all the uncertainty of the world. The actuaries tend to have the sense of like, you know, okay, if we have to include uncertainty in the equation, then we need to maybe charge more to allow for that uncertainty, and hopefully the fact that we can adjust it based on new data can then allow for a more specific target. I would also say, to the point of like, can they go up or down? I would say that if we set the target last year when inflation expectations were X, like I think there would be a rationale to say, hey, wait a minute, like, you know, we're in a happy situation where we are not realizing the worst fears of our inflation, and we can. And we might be able to adjust downwards. I know politically that might be a tougher sell, but I would hope that's looking at both that could work in both directions. And again, in the statute, there are things that are in the statute with regard to consideration. So I you know, we recognize that, but I do think I appreciate what my colleagues said, Joan and others, about just try if we go down this path, then I think the board should have, you know, be clear about what it is, and that it's not like normal course of business, but it's sort of, well, you know, we are facing something akin to the Great Recession or a pandemic or like a major thing rather than the normal ups and downs of an economy.
Yeah, and let's be honest, it's much harder setting a spending target value now than it would have been 5 years ago.
Janice, please go ahead.
In the case of Massachusetts, though, I think it's important to point out that, you know, some of those bad actors, like it was Beth Israel, right, that was called out, or Mass General, I can't remember which, but Mass General.
Yeah.
It- I think one could argue that the stick wasn't hefty enough for many of those healthcare entities to keep on target. And so what we saw with Mass General is that that despite the fact that they had these healthcare or these cost targets, it was easily dismissed, which I don't think is necessarily the case with OCA, the way it was it's structured.
Yeah, I mean, I'll say I'm amazed at how the commercial market healthcare spending slowed in Massachusetts for the first several years, because except for a pretty soft performance improvement plan, there were no consequences for exceeding it. And I wouldn't have predicted that, but it did work for a while. I don't know why.
So I think the conversation already kind of went there with Anthony's remarks. The board does have the power to adjust. It's just we're looking to you if you want to provide guidance on when it's appropriate for them to adjust. And yeah, if you have any further suggestions on parameters, we would welcome that.
Ken Stewart?
Yeah, I don't know how you can define that. Usually the way our health plans are designed is you have exceptions to certain limitations for emergent or urgent care, as opposed to an exclusion. And I think in this case, the board logically would be in a position, if something was urgent or emergent, to know that something needed to be done. I don't see how we can define the if and when, or if and then.
Carolyn Nava, did you want to weigh in?
I just want to roll back to Joan's comments a moment ago that it's not so much about their authority to be able to do so. We're here because we trust that they would be doing what's in the best interest of our communities. That voiced disclosure and transparency. That's the key.
And I also just want to remind folks, I think Joan reminded us of this earlier around progressive enforcement. If, you know, the board will set the target and the board can choose whether to make an adjustments or not. And then the office in the course of enforcement will first sit down with the entity that exceeds the cost target and try and look at the data and understand it. And there is there are several steps for enforcement. So if there's a Sovaldi explanation or some other, unusual explanation, then there's certainly no intent to pursue enforcement actions.
Okay, one more slide.
So these are our next steps. OCA staff will present a proposal to the board for spending target values and related policy questions during the board's December meeting. We're going to meet with you again in January to consider the proposed model and the board members' suggestions for modifications to our staff model. I know some of you had questions earlier in the meeting about sequencing of board and AC meetings. So do want to emphasize that you will have an opportunity to provide feedback on the spending target value. And we'll be able to relay that feedback to the board before they ultimately vote on it. And I'll turn it back over to our facilitators.
Sure. I think it is time for general public comment. And so we will do that now. We'll look for individuals to step to the podium. We'll also look for virtual members to use the raised hand feature. This is general public comment, period. And we have someone in the room who's coming to the podium. We'll start there.
Just one real comment, a quick comment. Ben Johnson from California Hospital Association. We do believe the adjustments that were discussed, such as aging, chronic disease, and disability, are appropriate to continue to consider and important to really account for if the office is going to truly account for some of the uncontrollable and underlying drivers of healthcare costs in California. Just want to align then in addition with Mr. C in asking for the office to really share the analysis on aging as well as the other adjustments. We've previously shared with the office international studies, for example, of the impacts of aging on their per capita healthcare expenditures. Those tend to be much more significant than the adjustment that the office's analysis has shown. And so we would then want to apply that to California as well. And so we looked at national healthcare expenditure data, such similar to what the office has presented. It divides it by age, and we applied that to Department of Finance projections. And that showed a significant impact of aging on per capita costs in California. And so would love to understand more about that discrepancy. Thank you.
Thank you very much. We're looking to members of the public joining us virtually for any raised hands. We don't see any at this time. Just note for the record that there are about 40 members of the public still with us virtually, and about 8 members here physically with us in the room. Again, welcome people here in the room to come up to the podium if you'd like to make a general public comment. Seeing no one coming to the podium and still no raised hands in the virtual setting, I believe we can consider adjournment.
Terrific. If there are no other comments from advisory committee members, we will thank you for sticking with us, being so engaged with us till the bitter end. Ken Stewart.
I just want to end this on a light note, and market conditions can change. And even though David's not here, I just want to point out a year ago, you couldn't have got a free phone from your carrier. Now you can get 4 i15s for 4 lines at half price.
Good to know. And Vishal corrects me. It's not the bitter end. It's a terrific end with all of you, and we very much appreciate the engagement. So thank you all.
And on behalf of the board members, we thank you very much for your really valuable input. It's Rick Kroenig here.
And Happy New Year.
Indeed.